Good morning. We're going to go ahead and get started. Please pardon our delay. We're having a minor technical difficulty with our live streaming. So we are going to go ahead and get started, and we'll continue to work on that. So thank you for joining us today for the Rocky Mountain MS Center's Fall Education Summit. My name is Gina Berg, for those of you who I haven't been able to meet, and I'm the CEO here at the center. Through our education summits, we try to provide the MS community with the latest in research, treatment approaches, and strategies for living well with MS. The Rocky Mountain MS Center's overall philosophy is rooted in the concept of maximizing lifelong brain health. Through early and effective treatment approaches and incorporation of healthy lifestyle strategies, our program today is built around that core philosophy. I'd like to give a special welcome to our online viewers and thank them for their patience as we try to take care of this glitch. I'd also like to take a moment to thank our exhibitors today. I hope everyone has time to stop by during a break or have already stopped by and visit with them, especially Accorda Therapeutics, Biogen, EMD Serono, Sanofi Genzyme, Novartis Pharmaceuticals Corporation, Teva Neurosciences, Genentech, and Accessible Systems. It's quite a list. I don't want to forget anybody. We also have a patient education program grants and sponsorship from AbbVie, Genentech, and Novartis Pharmaceuticals. So we thank them all for allowing us to do what we do today. Without further ado, I'd like to introduce Carrie Chahovic, who is our Director of Programs at the MS Center. One of Carrie's primary roles is liaison between the MS Center's nonprofit and hospital arms, and she's serving as our MC today. So again, on behalf of our whole team, thank you for joining us today, and we hope you enjoy it.
Thank you so much, Gina, and good morning, everyone. Thank you again for being here. As Gina mentioned, we do have a great agenda for you this morning. It really does showcase the unique partnership between the Rocky Mountain MS Center, University of Colorado, and University of Colorado Hospital. First, we'll be hearing from Drs. Timothy Vollmer, John Corboy, and Enrique Alvarez, followed by a Q&A panel where you'll have the opportunity to ask doctors any questions that come up for you during the presentations. Our speakers will then be followed by a healthy lifestyle panel with Jeff Hebert, Holly Pren, Michelle King, Stephanie Larson, and Linda Makutis. The panel will be moderated by Pat Daly, and we'll focus on incorporating wellness strategies into our lives. Our speakers will explore the idea that wellness is not a goal. It's a truly active, ongoing, individualized process that takes different shapes and includes various strategies for individuals. We'll have 2 breaks during the program. The first is 20 minutes, and the second one is 10 minutes. These breaks are really an opportunity to both enjoy refreshments and to connect with fellow participants and attendees here today. So we hope that you take the chance to do that. I would, in that vein, like to draw your attention to the cards that are on your tables. Those are fun little conversation starter ideas that we hope will kickstart some good conversations between the other guests here today and yourselves. The complete PowerPoints and recording of the summit will be posted on our website at mscenter.org. And I would like to point your attention to a very important piece of the packet today, which is your evaluation form. We take your feedback incredibly seriously as we consider our programming for upcoming events and education summits. So we have an education task force made up of patients, clinic staff, and others, board members and staff here at the center, that we really thoroughly evaluate what your feedback is and root our next programming plans in that feedback. So thank you for taking the time to do that. You can put your evaluations on your table as you leave or in the box out in front. So with that, without further ado, I would like to introduce Dr. Timothy Vollmer, our medical director at the MS Center and co-director of the Rocky Mountain MS Center at University of Colorado, who will be discussing maximizing lifelong brain health. Thank you so much.
Thank you. So again, my welcome to those of Carrie and Gina's. It's a pleasure to see you here and hopefully the folks online. And our goal here is basically just try to address questions and issues that you have. We're going to start out with some short presentations in terms of just providing an update to where we're at in MS. Oops, that didn't work. I'll get it eventually. This is the disclosure slide. You'll see that from all the physicians to just let you know we do work with companies and NIH and in many different ways. And if you have any questions about that and why we do that, feel free to let us know. These companies do actually pay us for the time when we consult with them. So the goal for me right now is to discuss a major breakthrough in our understanding of the immunology of MS that has occurred over the last year, year and a half. And then go on and talk a little bit more about maximizing lifelong brain health and what that really means. And also discuss what you can do in a general sense to really maximize your own brain health. And this is not relevant just to MS patients, it's relevant to all of us, because brain health is an issue that's emerging as a more important target than ever before for us as we go through life. So the first thing I'd like to emphasize is that multiple sclerosis is written as a disease of myelin in all the textbooks and all the websites online, but it's not. It's a disease of the nervous system, and the more important target actually are the neurons, the nerve cells in your brain. Nerve cells are damaged just as early as the myelin is, and they are killed, and they are disappearing from the brain. And our primary goal with the therapies that we use is really try to protect those nerve cells. We also protect the myelin-forming cells, but the really important thing is to protect nerve cells, and that's increasingly being recognized around the world. There are also other cells in the brain that are not the myelin-forming cells, but also very important in the disease process. These are called glia or astrocytes or microglia. And we're learning more about how those cells play a role in this disease and also how they participate in the treatments that we use. So MS is an inflammatory disease. It's a disease where the body's immune system attacks the brain. And there's a specific part of the immune system called the lymphocytes that drive this disease. And there's different varieties of lymphocytes, many, many different varieties. But the key ones for our conversation are the T lymphocytes and the B lymphocytes, also called T cells and B cells. And I'm going to talk a little bit about what we've learned about these and why this is really an exciting time for us. So the first thing in MS, MS is described as a relapse-remitting disease or a progressive disease. There's two forms of progressive disease, secondary progressive and primary progressive. Much of the world thinks these are different diseases. I don't. They have all the same biological characteristics. The only real difference between them is that the patients that are in a relapse-remitting stage still have neurologic reserve in some system, maybe related to walking, maybe relating to memory. And the patients in progressive disease have used up that neurological reserve, and they've unmasked several other factors that I'll talk about. So untreated, about 70% of patients will enter the secondary progressive phase of disease by 15 years of disease duration. That's untreated, natural history. There's also another 15% of patients that will never have a relapse and will end up just in the progressive phase of the disease, and that's called primary progressive MS. So 85% of people start out with having attacks or relapses, and 15% don't. But as the patients go through the disease, everybody can end up at the same point if it's not treated. So the next slide is really what I think is one of the most fundamentally important observations made in recent years. So we all have lymphatic systems. So we know about the vascular system where you have veins and arteries and a heart that's pumping fluid. But you have another vascular system that's entangled with that. And these are small vessels that run throughout your body in almost all tissues. And they drain water and fluid from your tissues into the lymph nodes and ultimately back into the circulation. So it's the way you get rid of excess tissue water. But the other thing it does is that as this fluid moves back in the lymphatics and goes to the lymph nodes, it gives the immune system a chance to survey it to see if there's something going on that they should respond to. So if you have a bacterial infection or a fungal infection, those molecules will be carried through the lymphatics back into the lymph nodes and spleen. That gives the immune system a chance to react to it, and then they develop special cells to go and attack that, and they leave the lymph node, move back into the blood, circulate back to the site wherever it is, and does battle with it. So the immune system, this part of the immune system is extremely important to help you cancer, infections, and also to help heal wounds. However, it's been thought for almost 80 years that the brain was special, that it didn't have these lymphatics, and so it wasn't connected to the immune system, and it's been called an immunoprivileged organ. And that's always made it difficult for us to understand how the immune attack on the brain was being generated, because we know that cells are in the blood, are coming from the blood that attack the brain, but we didn't know where they were coming from. And so recently, a group in Virginia, a group in Sweden, were doing some other pathological studies, and they identified that in fact there are lymphatics. And so this is, get this, can you see that over there? Yeah, okay. So, yeah, okay, so this is the old concept. And the old concept was that the brain did not have lymphatics, these green tubes, and instead spinal fluid would just leak through the cribriform plate, which is part of the bone where your nerves that are involved in smelling that go into your nose go through. So the cribriform plate was one area where scientists thought maybe it's just leaky, and some of the spinal fluid leaks through that into your nose, and that then gets down into lymph nodes under your chin and around your ears. Maybe that was the way that the immune system is being stimulated by the brain. Turns out that actually is probably not a very important pathway. Instead, you do have lymphatics. They run along the surface of the brain, right next to the big veins. And these lymphatics exit the cranium, or the skull, through the normal openings you have for the jugular vein, the carotid arteries, and others. And they drain down into these lymph nodes that are called deep cervical lymph nodes. A group from Yale demonstrated that the B lymphocytes that are in the brains of MS patients are also in these deep cervical lymph node. And they also demonstrated that the B lymphocytes that are in these lymph nodes are reacting to something and maturing their ability to attack that target at a much faster rate than the B lymphocytes actually in the brain, suggesting that the B lymphocytes that drive MS are actually coming from these lymph nodes. Now, T cells are also involved, but the B cells seem to be the key driver. And now we know that these B cells are just like the prior lymph nodes, that these lymph nodes in the deep cervical chain also drain back into the vascular system through the thoracic duct. So the B lymphocytes coming from these lymph nodes have to move back into the circulation, just like all other lymphocytes do, and they have to circulate in the blood to the brain, cross the blood-brain barrier before they can cause inflammation. And the reason that we know that is because two of our therapies in particular that work in humans work specifically at those points. One of them is Tisabri, and Tisabri works by blocking the ability of the lymphocytes to, once they get to the blood-brain barrier, from crossing it. So they can get there, but they can't cross into the brain. And then rituximab and Ocrevus, they simply kill the B cells once they get into the bloodstream, again, preventing them from getting to the brain so they can't cause inflammation. And those are the two most effective therapies that we have. So this convergence of all this data that these B lymphocytes that are coming from these deep cervical lymph nodes are driving the disease is impressive, and it gives us a specific target now to look at in terms of the cause of MS. So now the immunology of it has also evolved a bit. So here I'm just a cartoon. This is a blood vessel here. These are the lymphocytes. They have to cross the blood-brain barrier. And when they get into the brain, something activates them and turns them on. And they proliferate. They produce a lot of hormone-like substances. Those hormone-like substances then activate the astrocytes, which are the major cell type in your brain, which is also part of the immune system. And it's the interaction between these lymphocytes and these astrocytes that then lead to various pathways that can kill myelin-forming cells and neurons directly. And exactly how that's done is still a little bit mysterious, but we do know some molecules that are important for this, including nitric oxide and tumor necrosis factors. So these oxygen-free radicals make a toxic environment in the brain, and we think some of our therapies are working by inhibiting the production of those. So this immunology now has given us multiple targets for therapeutic intervention. We can target the B lymphocytes, we can target the ability of lymphocytes to cross the blood-brain barrier, and we also can target these astrocytes here with drugs that prevents them from turning into these aggressive inflammatory cells, blocks that pathway. Laquinimod, which is not being approved, Gilenya and Tecfidera seem to have mechanisms that inhibit these activated astrocytes. So this gives us multiple targets in the disease and is an exciting time for us. So I'm going to switch to the concept of maximizing lifelong brain health. Neurological reserve is what we're trying to enhance in the programs to maximize lifelong brain health. Neurological reserve is just a concept. It's a concept that relates to the capacity of your brain to compensate for injury. So that could be closed head injury in playing sports. It could be an infection in the brain, or in the case of MS, it could be the inflammation that damages the brain. So in MS, about 90% of the new lesions that form in the brain are clinically silent. The patient doesn't know that they're occurring, and that's because of neurological reserve. The brain has enough buffering capacity that it can find ways to get around the areas of injury and still maintain normal function. Also, if you do have symptoms develop, the brain has the ability to rewire and repair itself, and that's also related to this concept of neurological reserve. There are different components to it, theoretically, in the medical literature. So the brain reserve is a term used for the innate ability of your brain to compensate for injury. So this is determined by genetics and early life activities. So the more active you were in early life, more education you had, also the bigger your brain were, the more reserve that you have. However, you can also induce more reserve, and we call that as active reserve or cognitive reserve. And what we mean by that is that if right now all of us in this room can increase our brain's ability to compensate for injury and for normal aging effects by exercising, reading, doing art, socializing, pretty much anything that uses the brain in a creative way helps make new connections between the nerve cells that you have. And by increasing the size of that network, you give the brain more flexibility to shift things around if there's a problem with one part of it. So neurological reserve is a very important concept, not just for MS, but again for general health and many other neurological diseases. So one of the correlates of neurological reserve, as I said, is the size of your brain, how many neurons you have. So your size of the brain reflects how many neurons that you have. And in multiple sclerosis, there's a direct impact on brain volume. Now, brain volume for us tends to peak around age 5. And then it's pretty stable until about age 30, 35, and then it begins to decrease in all of us. It's just part of what life is. So starting about age 30, 35, the brain begins to shrink at a very slow rate, about 0.1% per year. And the rate of that brain volume loss gradually accelerates when we hit our 60s, where I'm at, to about 0.3%. So that's just normal. So the neurological reserve I've been talking about is active for normal aging. It's what allows us to continue to have normal function, even though our brain is getting smaller as just a result of normal aging. So we want to preserve neurological reserve so that it can be there for aging. We don't want it used up for multiple sclerosis. And that's why we would recommend treating MS as early as possible with the most effective therapy that has a good safety profile for you. In multiple sclerosis, the rate of brain volume loss is 2 to 7 times greater than it is in age-matched healthy controls. And the rate of brain volume loss predicts the future more accurately in terms of disability, more accurately than any other measure that we have. And so monitoring this, that as we do in our clinic, we think is a very important aspect of the future management of MS, and I think it will get better as we go forward. The inflammatory therapies that we use, all of them, rituximab, Gilenya, Tecfidera, Copaxone, interferons, all have some effect on slowing down this rate of brain volume loss. I mean, as I'll show you, the newer therapies, though, are significantly more effective at doing this. Just want to emphasize that the brain volume loss is due to the MS attacks and to the active lesions on your MRI. So this is a study from 2004 from the Italian group. Basically, what we're looking at here is a group of 60 patients that underwent brain MRIs on a monthly basis for 6 months and then had another brain MRI at month 18. And what you see here is the rate of brain volume loss dependent upon how many lesions they have. So these patients had no lesions and had very little change in brain volume. These patients had up to 25 lesions during that 6-month period of time, and their rate of brain volume loss is increased to 2.5%. Over here, we're doing the same thing. We're just looking at it from the standpoint of the volume of the MS lesions that they have in the brain. The important point here is that the brain volume loss that we're looking at here is over 18 months, but the inflammation was only over 6 months. So a very important concept from this is that if you treat the inflammation, it's still going to take about a year or so for that effect to be seen in terms of the decrease in the rate of brain volume loss. And we see that in the clinical trials. The other thing here are these values up here. These are called R values. And they're a statistical way to estimate what percentage of the overall effect on brain volume loss is actually caused by this inflammation. And it turns out that 75 to 85% of all the factors that determine how fast the brain is going to decrease is explained by this observation alone. That makes it a very important factor. This is just another way. Just ignore everything back here. Just look at this front line. This is looking at whole brain volume. And the green is the amount of brain volume loss that occurs in MS patients, and the blue-purple is the normal brain volume loss that we all have. This is in 30-year-old patients. This is in 60-year-old patients. And what you can see in the 30-year-old patients, essentially all the brain volume loss is due to MS. But as we move up to the 40s, 50s, and 60s, more of that brain volume loss is actually just due to normal aging, and the amount of brain volume loss due to MS is decreasing. And that's because the rate of inflammation is decreasing, and Dr. Corboy will go into that in more detail. This is direct evidence from MS patients on whether this is relevant to MS. So over here, they're looking at the size of the brain and the ability of the patient to do certain cognitive tests. And so brain volumes are larger out here, and they're performing better on the cognitive test. Down here, we're looking at the ability of the brain to compensate for increasing MS plaques in the brain, the T2 lesions, by virtue of brain size. So these are the patients that had a larger brain. They were able to continue to perform on the cognitive test even though the T2 lesions on their brain increased significantly in numbers. The patients who had smaller brains, though, had more of a decrease in their cognitive performance because of the increasing MS plaques in their brain. This side, though, for me, is one of the most exciting things because this indicates we really do have ability to impact this. So here, they're controlling for the size of the brain, and instead, they're plotting people based on how active they were in their early life. How much schooling did they get? How much sports did they play? Did they do arts? Did they read? All of those things. And that's called cognitive leisure activities. And what you're seeing here is that those patients that had more cognitive leisure activities, they were active physically and intellectually, had better performance on the cognitive tests. And they also were better able to buffer for the increasing MST2 lesion load versus people that had less education and less activity in early life. And the biology of this, again, is related to making more connections between the nerve cells that you have. So as you have an active life, as you learn things, as you interact with people, as you do art, you make more connections between the nerve cells. That gives the brain more flexibility in shifting function around in case there's injury. This is not relevant just to cognition. This is from the same group, and they're simply looking at brain size and ability to compensate for increasing disability. And so these are patients that had larger brain volumes. They were followed over 5 years, and they had relatively very little change in their disability score, in the EDSS. And these patients had smaller brains, and they had more of a change in physical disability. So this is relevant to all aspects of MS. This just summarizes all of that. Just pointing out that we have relapses here, but we also have a lot more inflammation in the brain that's clinically silent, but yet damaging the brain, causing the brain to shrink here. So this is the normal brain volume loss. This is MS brain volume loss. And I would argue that as the brain shrinks, it uses up that neurologic reserve, and that's the point and when people enter the progressive phase of the disease. That it's not a change in the biology of MS, it's simply a reflection that the brain, in certain pathways related to motor function or balance or cognition, that those pathways now are damaged enough they don't have reserve capacity. So just normal aging will cause them to slowly get worse. And certainly any more MS disease activity will as well. And so we're developing more therapies to try to deal with this phase out here, and there'll be some new drugs coming out of this next year that specifically are targeting this progressive phase of the disease. But if we can treat back here for the next generation of MS patients, hopefully in this one generation, we can fundamentally change the course of MS. And so we've already talked about this. So the categories of therapies that we have, we use these terms here. So they're the first generation, first line drugs, which are the interferons, Copaxone, and Albagio. Then there's the second generation of first line drugs. These are drugs approved by the FDA for first line use, and they include Tysabri, Gilenya, Tecfidera, and now Ocrevus. Then there are other drugs that you will hear talked about at various sites and various physicians, and they are in the list that we call third line drugs. These are drugs because of safety issues we do not recommend using as first line drugs. And they're really not more effective than these drugs. They're just different. So this is Lemtrada, this is Mitoxantrone, this is Zimbrida. And then I also put Tysabri in this category if the patient carries the JC virus because of the risk of PML. So these three classes of drugs now give us a lot of opportunities to tailor the medication specifically for the individual patient. Oops. These drugs do have different effects on preserving brain volume. So the second generation drugs and the rescue drugs have a bigger impact on preserving brain volume than the older medications do. They also have a bigger effect in reducing relapse rates. This is from an organization called Institute for Cost and Effectiveness Research. So it's not our plot, it's another group's plot. And the same thing is true for disability. So we do have ability now to really use far more effective therapies in patients at a much earlier stage and just as safely as we can use the old therapies by just careful patient selection and monitoring. And so it's opened up a new time for us, and we do think that we are at a pivot point where MS, in terms of future risk of disability, is fundamentally changing for the good. So thank you all for the time, and we'll go on to the next talks, and hopefully we'll be able to answer some questions in a few minutes as well. Thank you.
Thank you so much, Dr. Vollmer, for that excellent presentation. I do want to take one quick moment to let folks know if you're looking for a seat, there are some empty seats up towards the front. So if you'd like to make your way to the front, that would give you a little more space. We are bringing in extra chairs. We have a full room today, so bear with us. I would now like to introduce Dr. John Corboy, the co-director of the Rocky Mountain MS Center at University of Colorado, who will be discussing MS throughout your lifespan. Thank you so much.
So I'd like to expand the concept to also include the brain, because not just the brain, rather to the spine as well. Many of our patients have significant spine disease, but I agree, the goal is lifelong brain health, and we really focus on that because when we see someone when they're newly diagnosed, it's incredibly important to focus on the long term, not just the short term, and I think that's what Dr. Vollmer really focused on in his first talk there. And so there might be multiple different ways to approach multiple sclerosis, including avoiding developing it if all possible. And there's a bunch of research that's going on in relationship to this concept. Dr. Vollmer talked about the immune system, and the medicines that are all available presently today as disease-modifying therapies are those that alter the immune system function. And also, he alluded to as well, trying to protect nerves from dying. It's very surely true, as he showed, that early on in the course of the illness, the inflammatory attack is associated with degeneration of the nerves and with loss of reserve and with progression of disability. But as time goes on, as I'll show in a second, the nature of that inflammatory attack changes, and in fact, MS becomes mostly a neurodegenerative disorder. And protecting the nerves from dying is extremely important, both at the front end as well as the back end. We might try and enhance normal repair. We might want to perhaps replace damaged parts, just like a hip or a knee is replaced. You might want to replace damaged nerve cells. And then the good behaviors, the ones that we talk about all the time, not smoking, exercising, staying as close to your ideal body weight. All of those things are extremely important in terms of your entire approach over time. So the natural progression of MS is sort of the following. If we think about it, we can think about a preclinical phase, and there's a lot of work being done right now in the preclinical phase before someone has first overt symptoms. But the first time that most patients are really aware there's something is wrong is when they have their first event, an optic neuritis, a transverse myelitis, inflammation of the eye, the spinal cord, and perhaps the brain, that gives symptoms that results in seeing a physician. Over time, these relapses may accrue in the majority of people, up to 85% or 90% or so, and more of them occur over time. And with the second one, we now would say someone has clinically definite. They had 2 attacks of MS. They have clinically definite MS. But notably, over time, relapses diminish. And as Dr. Vollmer discussed, a number of people, the majority of people who are untreated, go into a slow progressive phase where relapses are significantly less common, and yet there's progression of disability. In addition, there's overall the progression of disability, although it at first accumulates, it is more significant as people age. The majority of disability that accrues with people accrues as they age because, as he notably showed, there is a significant amount of reserve, there's a significant amount of repair capacity when people are younger, but as people age, this diminishes. This is also manifested by an accumulation of the T2 burden, the little white dots on the brain scan. It's also associated early on with a lot of inflammatory lesions. The gadolinium-enhancing lesions after the injection of the contrast material are extremely common. After about age 40, 45, they actually diminish dramatically, and they're much less common as people age. And then in addition, cognitive dysfunction, as the reserve goes down, that is more challenging. And then, as noted in great detail by Dr. Vollmer, brain volume accumulates over time and so the overall brain volume diminishes with age. So what about this subclinical phase? Is there any way we can recognize a subclinical or preclinical phase? And there's been a lot of research recently on what might be referred to as the MS prodrome. That is, are there symptoms that might occur even before someone has that first optic neuritis, that first transverse myelitis? And there are incredibly a wide array of different types of data that support this concept of a prodrome before a specific clinical attack. And we can see decreased activity levels, literally just moving less in the large nurses study that was studied by Roberto Asherio at Harvard and others. Decreased cognitive function. Multiple studies from Argentina and elsewhere show that if you look at testing that's been done on individuals prior to a diagnosis of MS, for example, in school or as military recruits in Finland, you can see that those individuals that develop multiple sclerosis already on previously done testing have impairment compared to those who did not develop MS. There's data from Ruth Ann Mary up in Canada showing that depression and anxiety precede the first attack of MS. There's increased utilization of healthcare resources in the 5 years preceding a diagnosis of MS. We know that MRI lesions consistent with MS often occur before the first symptoms occur, so-called radiologic isolated syndrome, and there are numerous examples of this around the United States and elsewhere. And in addition, associated with those lesions, there's brain volume loss. Individuals with radiologic isolated syndrome, compared to age and sex-matched controls, already have diminished volume before they've ever had a first symptom of MS. And there's presently a study underway looking at Tecfidera, dimethyl fumarate, in patients with radiologic isolated syndrome compared to placebo to see if, in fact, treating extremely early in these individuals would make sense. So there is a prodrome of symptoms that occur even before someone has an overt attack of MS. And what it tells me is that the condition has been going on for quite some time. This is also manifested by when someone has their first clinical attack of MS. In most of the recent studies that have been done with so-called clinically isolated syndrome after their first attack, the average number of lesions seen on the MRI scans is anywhere from 17 to 35. So even though they've only had the first clinical attack, their brain scans and/or spine scans already show numerous lesions that have been clinically silent. So this disease has been going on long before the doctors ever hear about it, and long before the patients even really notice that there's an overt clinical symptom. And so this leads to the concept that we might want to try to identify ways to look at early risk factors, extremely early risk factors. And we've devised a study called RISE-MS, looking at risk factors in early MS, to look at genetic markers, to look at environmental screening, to look at a variety of known risk factors such as exposure to the Epstein-Barr virus, smoking, vitamin D, etc., in first-degree relatives of individuals who have MS. These are individuals who are at a much higher risk of developing MS, 10 to 20-fold increased risk. And we know that they also have about a 10% likelihood of having abnormal brain scans that look like MS, even if they don't have symptoms. And so the concept is to try and look at a large number of people, to do abbreviated MRI scans of the brain and cervical spine, focusing on brain volume as well as the lesions, the T2 lesions in the brain, to do a broad screen, an environmental screen, both clinically, doing paper and pencil questionnaires about activities and other things, looking at a variety of different blood markers of genes, immunological function, lipid markers. There's a significant amount of evidence now that elevated lipids are potentially associated with multiple sclerosis, to do activity monitoring, and then to compare those who have abnormal MRI scans to those who are age and sex matched who do not have abnormal MRI scans, but both of whom have first-degree relatives with multiple sclerosis, and then also to individuals who do not have first-degree relatives with multiple sclerosis who are the same age and sex, to try to determine if in this high-risk population can we identify specific markers of onset of disease activity so that we can in fact use that as a screening tool, much like a mammogram for breast cancer, that you would then try to identify people at the earliest possible times with multiple sclerosis risk. So then, what about people who go on then to have a first clinical event? And I would argue, and I think everyone in our group would argue, that it doesn't matter if you've had 1 event, 2 events, 6 events, you're all pretty much in the same area, we already have multiple sclerosis, even if you have not fulfilled formal diagnostic criteria. So I'm going to lump those two categories together. And as described, there are now, depending upon how you count, 15, 16, or 17 different disease-modifying therapies that are approved, including multiple generics now for glutathione acetate, and most recently, ocrelizumab approved earlier this year, all of which have significant impacts, as noted here. And we'd like to focus on the utility of these medications over time, but you can see the profound effects they have in a number of different areas. And already we've seen the argument for the aggressive therapy from the outset, with which I completely agree, but I want to focus on the fact on the bottom there. The disease-modifying therapies have all been shown to be less efficacious as people age, and that gets at how do we use these medications and when do we start and stop using them. If you look at the age in MS studies, and the relapsing MS studies on the top above the line and the progressive MS studies below the line, the simple difference between these is simply age. The studies show that people are about 11 to 12 years older in the progressive MS studies simply because progressive MS comes on at a later time frame. So this isn't surprising. But notably, the vast majority of the studies with progressive MS have negative outcomes. And so we're going to explore a little bit about what that looks like in a moment. Partly that's because they're looking at different outcomes. In the early studies, they're looking at individuals with relapses, new scan changes. In the people who are older with progressive MS, mostly we're looking at disability outcomes, and those outcomes have been mostly negative. But we can see, even in the early MS, the relapsing MS studies, there's a significant age effect. This is from the original Gilenya fingolimod study. And as you can see, circled on the bottom, if you look on the, let's see if I can make this work. The line on the right is essentially placebo. The line in the dotted shows everything to the left of that would be better with Gilenya in this case. Everything to the right of that would be better for placebo, and anything crossing over the line with placebo would essentially be no different from placebo. And what you can see here is that with regard to relapse rates, those under the age of 40 compared to those over the age of 40, those under the age of 40 had a profound effect, even well above the overall effect. Those under the age of, over the age of 40 were no different from placebo. That is, even using 40 as a cutoff, there's no documented benefit with Gilenya over the age of 40 for relapses. Similarly, this is for, I believe, for natalizumab, and you can see the same sort of issue, although it's still statistically significant for those over the age of 40 compared to under the age of 40. There's clearly a trend towards a greater benefit for those who are under the age of 40. But if you look at the outcome with regard to disability, those over the age of 40, no benefit with regard to progression of disability with this medication, which we really do truly feel is one of the best medications we have, if not the beta one. What about if we look at the older age populations? We look at the patients with progressive MS. And this is with the secondary progressive MS studies with beta-serin that were done in Europe and as well as North America at the same time. And you can see that there's no difference between placebo and North America, yet there is a difference with a benefit seen in beta-serin in the European study. So we asked, well, what was the difference? These studies were done at the exact same time. They were done virtually identically. How could it possibly be that we had a difference? Well, there were differences because the patients were not the same. The patients in Europe were substantially younger. The patients in Europe had significantly more enhancing or active inflammatory lesions on their scans, and they actually had more relapses that were recent and other things as well. So the populations were different. And even just a small difference of 5 to 6 years showed that the benefit was significantly smaller in individuals in North America who are a little bit older. The same thing can be seen with the recent introduction of ocrelizumab for primary progressive MS. If you look at the effects related to gadolinium and the effects related to age, here's the overall benefit. The overall benefit is about a 24% reduction in people who had a change in disability over the course of, in this case, about 120 weeks, which is sort of in here. So 24% reduction, or a hazard rate of 0.76. If you add the two together, that's 1. And so here's the overall population, 0.76. If you look at the effect of gadolinium-enhancing lesion, the benefit actually is greater. It's 0.35 or 35%. And if you look at those who don't have enhancing lesions, the effect is smaller. Similarly, with age, if you look at those under the age of 45, and 45 was the median age in the study, compared to those who were over the age of 45, again, the hazard ratios change substantially. Those under the age of 40, that number goes to 64% hazard rate, or about a 36 benefit, as compared to a 24% benefit. So similar to numerous other studies, progressive MS, relapsing MS, the same issue holds, that age matters with regard to the presently available disease-modifying therapies. So then what to do about progressive MS? As people enter progressive phase, they have less enhancing lesions, less active inflammation seen that way, less active relapses. 95% of all relapses occur by age 55. In addition, even the relapses that do occur are less significant as people age. So is there some way to help protect the nervous system cells from dying? Is there a way to enhance the brain reserve and the active reserve as referred to by Dr. Vollmer? And there has been some work on that, and I'll come to that in a second. But the issue with regard to the use of the disease-modifying therapies is, should we continue to use these indefinitely, or is there a time when it is relatively safe to discontinue these medicines? And there's some evidence that you may be able to do this, but there's not anywhere near enough. This is from the MS BASE study done by the Keystone colleagues, looking at individuals who essentially all their information is placed into a database, and then the patients are followed through the database. And they looked at people who stayed on medicines compared to those who went off of medications. And the patients went off of medications for a variety of different reasons, and the average age was about 45, and they only included those individuals on the older injectable therapies. And what they showed was that there was really no difference when you follow people through the database and people who stopped and stayed with regard to relapses. But notably, there was potentially a small worsening that occurred after about 2 years of being off of therapy with regard to disability progression. And it's not clear if that's specifically related to going off the medication or to other factors, but at least it's a concern that, at least with people who are 45 or so as an average age, that there could be some concern about going off medications. Here's another study, though, from Austria, a similar kind of study in a database, and notably what they showed was a very similar outcome with regard to relapses. The hazard rate was only about 0.06, or a 94% reduction in hazard or likelihood of having a relapse if you're over the age of 45 and had 4 years of relapse-free time while you're still on a disease-modifying therapy, suggesting prolonged stability really was associated with a low risk of recurrence by that mechanism. And it, not surprisingly, also showed that the risk of having disability progression was associated with the age of the patient being older, the disease duration being older, and the amount of disability at discontinuation, all of which we know from prior studies. So this leads to the study that we're presently underway. We've enrolled about 59 people so far in the so-called DiscOMS study, looking at patients who are 55 and older who have had prolonged stability, who've not had a relapse, who've not had a scan change. And the hope is that we'll be able to define whether it is safe or perhaps is not safe to discontinue disease-modifying therapies in this patient population who've been relatively inactive with their disease over a prolonged period of time. And we hope to have the data on this in about 2020 or so. And I'm gonna skip ahead just to get to this right here. So if these medicines are not helping as people age, if that's true, and if we know that there's ongoing loss of brain volume, excuse me, dropout of brain cells as people age, are there things that we might be able to do that would help protect against that cell loss over time? And there are. And so a number of studies have been done recently that focus on perhaps antioxidation. Dr. Vollmer showed that there are some oxidizing agents in the brain and the spine that occur with these inflammatory attacks, and several antioxidants, such as potentially Zocor, one of the drugs that is used to treat high cholesterol, perhaps alpha-lipoic acid, are antioxidants, both of them. or perhaps otherwise that might enhance energy production inside cells to help them to maintain their cellular integrity and all their cellular functions. Vitamin B7 or biotin, a study suggests that that may be helpful. And then also just recently, a month or so ago at the ECTRIMS meeting in Paris, Bob Fox from the Cleveland Clinic announced the results of the IBULAS study in which we participated as well in individuals in their 50s with progressive MS, showing a 47% reduction in brain volume loss compared to placebo. By comparison, ocrelizumab in the same patient population of people, in fact, even a little bit younger, showed a 17.5% benefit in brain volume loss compared to placebo. So all of these are approaches that focus on not altering the immune system, but focus on helping the maintenance and the restoration of power production inside cells so that they will hopefully not die and drop out. And that's just the Zocor data. So this just gets at then, in terms of lifetime treatment, with regard to the disease-modifying therapies, we'll find out if very early treatment is necessary or helpful. We know that it's helpful in this range and here in the middle, but we're going to see with the DiscOMS trial whether or not treatment as people age really is necessary or helpful. But all these other approaches are other approaches that I think will be important, some of which maybe we want to use throughout the lifetime. Guess that died. Throughout the lifetime of the patient, including, for example, neuroprotective approaches, because again, helping with cognitive reserve, brain reserve at the front end may be, well, extremely important, not just at the back end. So I think the top 5 points are listed there. MS begins before even the first overt attack. MS changes throughout the lifetime of the patient. The MS DMTs that are presently available, disease-modifying therapies that are presently available, have the greatest impact when used early and aggressively. It may, we don't know, it may be safe to discontinue MS DMTs as people age, and research going forward really needs to focus on these protective approaches, repair approaches, and approaches that perhaps will even replace damaged parts in the nervous system. So thanks for coming in, and thanks for taking part of your Saturday with us today.
Excellent. Thank you so much, Dr. Corboy. With that, we are timed for a 20-minute break right now. So it's a chance to stretch your legs, grab another refreshment, chat with your neighbors, get to know one another, and then we'll reconvene back here. We'll try to reconvene in 15 minutes. If that's okay, just start making your way back in so that we can stay on track and be respectful of your time. Enjoy. Thank you. One last note, if you do have any questions that came up for you during Dr. Vollmer and Dr. Corboy's presentations, just jot those questions down on the note card and we'll be collecting those.
Good morning. My name is Jules Kelty. I'm the Director of Development for the Rocky Mountain Multiple Sclerosis Center, and we're just going to take a quick moment to tell you about an opportunity that's coming up on Tuesday, December 5th, that we call Colorado Gives Day. It's 24 hours of online giving throughout the state of Colorado, and this year they have a $1 million incentive fund. And why it's important for us that if you will consider a donation is the more money we raise on that day, the larger percentage of the incentive fund that we have access to. Our board of directors and subcommittees have also pooled a $5,000 500 leadership match for any donation scheduled ahead of time. Where the funds go, just a few details. So the Ed Summit, that's one of the ways that we provide to the community. It's free to everyone dialing in and also here today. And actually, we support seed ideas within research. And so the RISE MS project that Dr. Corboy was talking about, that is being funded solely by private philanthropic dollars. So your donations make a real impact on the services and programs that we're able to provide to people. I was just talking with my table in the back, and they said, Jules, you better make sure to tell them the mechanics of this. So it's really important that when you go online, you use that website, coloradogives.org/MS Center. If you just go to coloradogives.org, you're going to have to type in MS. You can type in MS Center, and we'll be the top that comes up, but you'll have to go through a little bit of searching. So the easiest way is just to put in that website. Also, at the back of your program is an ad for Colorado Gives Day, and so if you take that with you and you want to fill it out later, you can do it then. So I just want to say thank you for considering this. Donations of $10, $20, $25, when we pool all those funds, it makes a tremendous impact on the MS community. And so thank you for considering us, and thank you for keeping us in your thoughts on December 5th.
Thank you, Jules. And now I would like to introduce Dr. Enrique Alvarez. Dr. Alvarez will be discussing MS research updates with you today. Welcome, Dr. Alvarez. Hold your applause and then make it really good. I would like to say, just a reminder, the Q&A will follow Dr. Alvarez's presentation directly, so make sure you're writing down your questions, and we'll have volunteers coming around in about 5 or 10 minutes, okay? And with that, I'd like to introduce Dr. Alvarez.
All right, well, thanks a lot for coming in. Can people in the back hear me okay? Perfect. So I'm going to give some updates that are related in I think, a few recent papers of research related to MS. ECTRIMS is the big European MS meeting. I should actually throw in, this one was actually combined with the North American MS Society as well. So this was a really big meeting with about 10,000 people. And unfortunately, we had to go all the way to France, so, poor us, to do this. It was in Paris, and it was kind of cool. Just, we'll talk about new stuff, but it was kind of cool. I got a chance to go to the Salpêtrière Hospital, and the interesting part about this is where Charcot kind of set up his career and described the first cases of MS, and these were some of the drawings that he drew. So it was kind of nice to kind of be able to go and see a little bit of the history of MS as well. See if I can figure this out. These are my disclosures, and because I'm going to talk about everything, pretty much all of these companies will be involved with some of the parts that I discussed about. So I'm going to provide initially an update on relapsing therapies, then talk a little bit about some updates on progressive treatments, and then kind of a miscellaneous category, random things that kind of will come up as updates from this meeting. And so as we keep adding new treatments for multiple sclerosis, we got data on probably the next drug that will probably be submitted to the FDA for approval here in the United States. That is ozanimod. It's a fairly similar compound to fingolimod or Gilenya, in that it's a little bit more specific, with the idea that it hits only those 2 receptors, as opposed to Gilenya, which hits also the 3rd and 4th S1P receptors, with the idea that maybe it has fewer side effects. There were 2 phase 3 studies being presented. There was the Radiant study, the Sunbeam study, and they were compared against Avonex. And they had 2 different doses, and so those are the reductions that you can see on the board for how much they reduced attacks. And so these drugs worked. I think the interesting part was kind of trying to see about safety issues. One of the interesting parts is they did a titration, so you started the drug a little bit more gradually. And with that, they were able to not really see a lot of the heart issues. And we'll have to see with Gilenya, for people that are on it or were reading about it, this first dose observation. So we'll have to see if maybe with some of this titration, they can skip the first dose observation, for example, or not. And so more to that to come at some point. They did not see a change in CDP is for confirmed disability progression. And so more information as well on some of these metrics. We also got information on Gilenya itself, but on a pediatric study. So this was the first time we had a drug actually studied in kids, and they compared it against Avonex, and I think it was very impressive results. As you just got done hearing this morning about sort of the effects across age, I think that definitely influenced sort of the results of this study. And you can see this reduction of almost 82% in attacks, which is unheard of. And especially when you compare it in an adult population, the reduction tends to be closer to about 55% or something like that. So very good effects in the pediatric population. That was on relapses. This is the effect it had on MRI measures. So as you kind of look over here on the left, the effect that it had on T2 lesions, so just kind of any scars. On the right, those on active lesions, and you see these reductions. I think we're kind of then having to learn a little bit how to interpret these studies. We usually have a bigger effect on MRI measures than we do on attacks. This was a little bit reversed, and so trying to figure out what that means and how to interpret that, we'll have to see. There's 2 more other studies in pediatric patients, and so we'll see if this is a consistent finding across studies, or if this is something that's going to be much more kind of specific in the quirk of this study, for example. The adverse events and things like this, there was nothing that really kind of came out in this 2-year study that kind of was out of line with what we tend to see in adults either, and things like that. We heard about another phase 3 study, this Concerto study with Lacuna. Instead of going for attacks, they went for confirmed disability progression. It was a relatively short study for 15 months. And this study on confirmed disability progression did not meet its endpoint, probably meaning that the drug will not be pursued as far as coming on the market for MS. This was the 3rd phase 3 study that had 1 positive study. This is the second one that wasn't positive, although it did meet the endpoint on relapse, reducing the number of relapses. And so we'll have to see. It had a pretty good effect on brain volume loss, and so whether it gets pursued for progressive indication, we'll have to see. And that study in primary progressive we'll be hearing about later on this year, I think. The next drug behind ozanimod to possibly come to the US might be cladribine. This drug was approved already in Europe just about a couple months ago. And so it hasn't been approved in the United States. This drug was on track to be the first oral medication to get approved in the United States back in the days when Gilenya got approved in 2010. And so we'll have to see, but there were some concerns about cancer risk. They did a second study. The number of cancers that were seen in the second study were very low. And so they're trying to re-pursue the approval for this treatment. It kind of fell in line with, similarly to other oral drugs, and they presented here sort of some extension data. They didn't see any increased risk of cancers or things like this, so very much kind of confirming kind of what we already knew. Their studies are actually older because they were initially done back in 2009, 2010 when they were seeking the original approvals. But here was some kind of extension data, kind of looking at the data a little bit differently. And again, no new concerns about side effects and efficacy, kind of in line with what we were expecting. So those were kind of big studies. There's a lot of data that's getting presented as well, sort of from real world data. This was some of the work that one of our research coordinators presented. And looking at sort of some of the comparative effectiveness using you guys as some of the study subjects here. So you'll be part of those lines. If you were on either NTZ is Tisabri, natalizumab, FTY is Gilenya, and DMF is Tecfidera. And so we can see that these were reasons that led to discontinuation. Overall, the discontinuation rate for Tisabri was very similar to Gilenya and better than that with Tecfidera. We can see that for disease activity in the second column, that it had better results from an efficacy standpoint. When we look at sort of just side effects or sort of the effectiveness a little bit more in detail, when you look at relapses, we could see that it wasn't statistically better than Gilenya with enhancing lesions. It was better than Gilenya, not better than Tecfidera. When you kind of combined all these things, we saw that Tisabri was doing better than Tecfidera and Gilenya. And so kind of showing things that we've kind of sensed in clinic already, but kind of confirming sort of what our findings were. This is a busy slide, so I hope you memorize it. This is to show a little bit, this was studies that some of you participated in, blood-wise at least. So we were interested in this question of, with ocrelizumab being presented and kind of being available now, how much does this drug differ from rituximab because of some of the differences between the two drugs? So ocrelizumab is a little bit more humanized. How it kills cells is a little bit differently. And so we were interested that when patients get infused, do the number of these chemicals that are being released as part of the destruction of those B cells, are they similar between the two drugs? And so we looked at a couple time points, so 2 hours and 4 hours. We compared the differences between the two drugs. And really the main point of it is there wasn't much difference between the two drugs. So a busy slide to kind of tell you that. And so more to come on this as well. You heard, so to kind of shift gears a little bit from relapsing to progressive disease. So we heard a little bit about Ibutolast. So the first top-line results of this drug came out. This is a drug that's been approved in Japan for a number of things. So for asthma, post-stroke dizziness. It had some studies that had sort of a small effect in brain volume in MS in Japan. And so there was a study through a program started by the NIH to look at sort of phase 2 type studies called NeuroNext that Tim Vollmer runs for our institution. So we were part of this study. And they looked at this drug with a bunch of different MRI and other measures to see if they could see a difference of effectiveness for this drug. And to really learn, I think, where the study is going to be really interesting as we follow this story is going to be what other outcomes can we look at to try and understand MS better, because it included a lot of OCT, so some of the eye findings where you can actually look at some of the nerve layers in these eye findings, for example, and things like that. So anyway, this drug does a lot of different things. Usually that means that we don't really know how it works, but there's a laundry list of things that it kind of does. So migration inhibitor factor, it inhibits that. PDE4, so prostaglandin something or another 4, and 10, toll-like receptor 4. So different effects it can do. And the primary outcome was to see whether or not it reduced brain volume. And we do see that it does reduce brain volume by 48%. And so it was a positive outcome. And we started to hear a little bit about some of the other things. So some of the other MRI measures that were getting looked at. So one of them is something I don't know much about, but it's magnetization transformation. This has to do with the integrity of the tissue. So what we are looking at is something called normal appearing white matter. So it looks normal on look, but when you start to look at some of these measures, you can see that the tissue is not quite normal. And when we look at MRI pathology tissue sections, we can see that the stuff that supposedly kind of looks normal doesn't really look that normal, that we can see some subtle changes, for example, and this is a way to measure that. And with this technique, there was a difference, there was an effect by the drug. When you look at another way to look at this normal appearing white matter and DTI, a different way of looking at it, this in MRI, this diffusion tensor imaging, there was no effect on that. And so, again, what that means and things like this, I think we'll have to hear a little bit more about. More importantly, on the side effect profile, there was a little bit of nausea, some softer stools, things like that. But other than that, it was pretty well tolerated medication. So I think there'll be probably more information coming on this and probably the thought of trying to look at phase 3 studies or repeating the study. So this is definitely becoming one of the leading candidates for kind of one of the next progressive therapies. Biotin, I think you heard a little bit about already this morning. These were some continuation, some further studies into this. They looked at brain volume effects of biotin, and the interesting part is biotin, especially at these high doses, tends to shrink brains a little bit. Probably not from a brain volume loss, but just because it dries out things a little bit. And so that's kind of where some of the headlines we're reading, that biotin shrinks brains. So sometimes if you have a direct effect on some of these other markers, it may not be a great marker for that drug in particular. So we'll have to kind of really wait on the big biotin study that's currently underway that Dr. Corboy runs for our center, to see whether or not it has an effect on disability progression, which I think will be much more telling than what these effects are on brain volume, especially with this drug. We learned a little bit about Tysabri, a little bit further study into this. So Tysabri was looked at in secondary progressive MS, and they looked at this in a little bit slightly different way, where instead of looking at the EDSS changes, they did a composite measure of something, whether you could either have progression in slowing down dexterity-wise with your hand, slowing down your walking, or that EDSS measure. And so when you looked at or statements as progression, either of those things, the drug did not work in progressive disease. But it did have an effect on hand function. It seemed like it slowed down hand function worsening. And then for the 25-foot walk, it looked like it had an effect as well on slowing down the rate of progression and making you walk slower. Double negatives there, so sorry about that. But basically, it helped with walking as far as not getting worse. And so I think it probably has some effect, but it's not probably going to have a huge effect. And so I think more to come on this as well. I think the possibility what this implies a little bit is that it affects things that aren't affected too much. So hand function tends to be affected later than leg function. The typical pattern is that things start to affect the legs and then they start to affect hands. And so if you're affecting something earlier in that progression process, that you might have a bigger effect a little bit along the lines of what Dr. Corboy was mentioning as far as treating things early with highly effective drugs. We had a little bit more of information. Dr. Corboy did some amazing digging as far as getting some information about subpopulations. And so there was information that he presented in one of his talks about the effect on different groups of patients that ocrelizumab looked at in progressive disease, and specifically primary progressive disease. So the big graph at the top left is the effect overall for the study. The Olympus one was the suggestion from rituximab. And from the rituximab, this Olympus study, there was a suggestion that the drug, well, not the suggestion, it worked better if you could look at subgroups in younger patients than those with active lesions. We had heard from ocrelizumab that it didn't seem to matter too much, at least statistically, although patients that had contrast-enhancing lesions or active lesions had more of an effect than those that did not have active lesions. I think the interesting part was then we found this information about younger patients, and I'm not sure about the pointer, but there we go. In younger patients with ocrelizumab, this is the important number, is what this number means is if you subtract this number from 1, there was a reduction of basically 36% in the chances of progressing if you were younger, then 46 if you were older. Your chances of having progression, the reduction of that effect was only of less than 12%. So definitely having a much bigger effect in patients that were younger than patients that were older. There was already some suggestion from this that the drug might be have more effect in women than in men, in men than in women. Also in patients that have a higher BMI, so that we're more in the obese categories, that the drug may not be as effective as well. And that might have to do with sort of one dose fits all thing. And so as we kind of look at these subgroups, I think we'll learn more about which patients may benefit more than others. Siponimod is probably going to be the next drug that gets approved as far as progressive disease beyond ocrelizumab. This one had a big phase 3 study that got presented a year ago. And so they did some extension studies and presented a little bit more on the MRI metrics. So they had MRIs on over 80% of the patients in the study. And so they presented sort of effects that they saw in brain volume and things like this. And the drug had an effect in brain volume, number of lesions for those, number of active lesions, because these patients could still have active lesions. And so still kind of inconsistency to kind of say that this drug seems to be working well and had a robust effect that, again, wasn't necessarily a huge effect, but was a decent enough effect that I think will add to sort of our arsenal of drugs for progressive disease. They were kind of going back and forth as far as FDA approval process as to what indications they might get approved in. So the FDA had suggested and were pushing them to just do for relapsing MS. They were pushing back because this was a secondary progressive, and with secondary progressive, you know, you have an effect on relapses, you have an effect on progressive, and so they've been kind of going back and forth. That's going to delay their FDA submission, but my understanding is in the first quarter of next year, we should get a submission to the FDA. So I think this will be the next drug that we see for progressive disease, potentially. To continue a little bit of the data on real world data. So there's a big study that's being underway, mostly at Australian sites, but as well with some sites scattered throughout the world that are part of this MS-BASE study. And so this was looking at the risk of progression, so patients that started off as relapsing remitting and their chances of kind of going on to having worsening of disability. And here comparing, for example, the conversion rate between interferon on the left and on natalizumab, and I think it's pretty clear that there's more, the reduction of going into that progressive phase with Tysabri versus an interferon is much better. To kind of start a little bit on the other categories, so there are the 27 criteria. They're getting introduced. They haven't been published yet. But it was basically the changes that we will see related to being able to diagnose MS. So we've been trying to push the boundary to meet the multiple part of multiple sclerosis as fast as we can, so we don't have to say, hey, let's wait for another attack, and now we can diagnose you and start treating you. And so what this criteria, the big jump, I think, is adding spinal fluid, again, into the criteria for relapsing MS to be able to say after that first event, if you have spinal fluid that looks inflammatory, now we can say, hey, you have MS. There was a few other things. They were looking at optic neuritis. They were talking about trying to increase the number of lesions in order to kind of make the diagnosis, and all that kind of died away. So the big thing that changed was the spinal fluid aspect of things. So we do a lot of brain volume. There was studies being presented that looked at how to measure these in the real world. And so we're starting to kind of see some effect of being able to look at this. This was not a comparative study between drugs, but between just looking at Gilenya patients and being able to kind of measure brain volume changes in the real world setting. The comparison, the middle bar versus the red bar, is looking at patients that had active disease versus those that did not have active disease, showing that more of the brain volume loss was in patients with active disease. There's a lot of data regarding neurofilament light. So there was some meta-analysis kind of showing, or some basically grabbing information to see how we can use this as a biomarker. So this is a protein that's being made by neurons, and we've had the levels that make it into the blood are really low, but there was a new technique that really lets you get into those really low levels so that we can actually start measuring it in blood. Otherwise, we'd have to do spinal taps every time we wanted to look at this, and that's not very feasible. And so a lot of numbers, but to kind of basically say, if you took blood sample at the beginning of a study, for example, you can predict later on what kind of brain volumes you might see. because again, it's a marker of nerves being broken down and lost. And so you can see what the effect is going to be on brain volume later on. And so I think that this is kind of giving us a window into sort of a better marker to kind of say what that, after you have an attack, for example, what your disability chances might be down the line. I think you saw the slide already. And so what it's saying is if you look at different parts of the brain as opposed to looking at the whole brain, that for certain areas like the ones in the back columns, the caudate, the putamen, that age versus the effect you might have on drug isn't probably that different. But if you look at certain things like the thalamus, the blue bars are kind of the effect almost done, as you can tell. So that the effect that you're going to see on age, which is in blue, as it kind of goes up, this is what you're going to lose from age. The green is the effect that you're going to have, that you could potentially have by starting a drug. And so when you look at the thalamic changes, that if you start the drug early, you can have a bigger effect than if you go later, where age is going to have a bigger effect. Until we can reverse aging, that might be a different process. Anyway, so the important thing, I think, is we're getting a lot of drugs. This is kind of what the landscape looks like now. We just had sort of another generic come in with, for Copaxone, another glutathione acetate come in as of like less than a month ago. These are all the drugs that are kind of in the process of getting approved, so there's a lot of options that are going to be coming along. And so I think with that, then we can turn this over to the panel. All right, thanks a lot.
Wonderful. Thank you so much, Dr. Alvarez. And now I would like to welcome Drs. Vollmer, Corboy, and Alvarez back up to the front of the room for our Q&A panel, and we'll get started shortly.
First, is there a correlation between MS and a child with a parent who has an autoimmune disease other than MS? And also, what is being done to reduce the time and duration to diagnose MS? That is the time between first clinical event and visit to doctor and formal diagnosis.
You want to talk about the other autoimmune diseases?
Yeah, so certainly, so MS traditionally was kind of thought of not having the same correlation with other autoimmune diseases that we kind of see patients with lupus have an increased risk of, family members having rheumatoid arthritis and other rheumatologic diseases. But as we look at this more closely, and I know Dr. Corboy, we spoke about this, we are seeing, and we ask about it every time in clinic, and it's very common that I hear, oh yes, I have a family member with Crohn's disease, I have a family member with another autoimmune disease. So I think there is really a correlation there. And I don't know numbers-wise, but that's something that could potentially be looked at in the future in terms of correlation.
So the gene signature kind of goes a little bit more with psoriasis, for example, but the clinical data hasn't really shown up. As far as kind of the diagnosis part of things, I think we still see that access to care is probably one of the biggest things, and trying to get in when you have symptoms to get evaluated remains sort of one of the biggest things. I mentioned a little bit about trying to change the criteria so we can kind of say MS and we don't leave you in limbo with, single sclerosis diagnosis or something like that. And so I think we're trying to kind of increase the diagnostic criteria so we can start diagnosing it earlier and earlier. But I think that the main point is still that if you have neurologic symptoms, especially in a first degree, in your kids, for example, or any other relatives, is to get checked out.
And one thing I started asking my patients, because sometimes it's hard to know, what some of these weird diseases, what the names actually mean. So I always ask, anyone in the family seeing a neurologist or a rheumatologist for any reason?
So, next question here, I'm just going to go through one. Is there a gene mark, or have gene markers been identified for MS, and are screening tests available for family members? As you just mentioned, depending on how you look at 35 to 50 genes that have been identified have some kind of impact on risk of MS, either decreasing or increasing the risk, but each one of them has a relatively small effect. And so doing gene tests to identify them doesn't really help very much in determining whether somebody's going to have MS.
But if I could add to that comment, there's some of you may be hearing about a test that, did that test get approved?
I think it's approved.
Yeah.
Yeah.
And it's an RNA test?
DNA, I thought.
Yeah.
Mayo Clinic test?
No, there's a test that was studied at Vanderbilt and a few other places that is purported to be a test to define if you have MS or not. It's just, I think, just gotten approval. The problem with the test is that they have not done an adequate set of control groups. They have specifically not looked at people who didn't have classic MS. So it's not difficult to diagnose MS in someone who's had an optic neuritis, transverse myelitis, and they have 50 lesions on their brain scan. So saying that this test works in that population is, with all due respect, useless. What they really need to do, which they have not yet done with this test, is they have not taken a bunch of patients with maybe 2 or 3 lesions on their brain, maybe some vague numbness in one limb, or something that may be MS but is not clear, and has shown that this actually predicts developing what everybody would agree upon is MS over time. So you may well hear about a test, either in your doctor's office or elsewhere, a test for diagnosing MS. I think there are significant limitations to this, but this is a gene-based test.
Okay, along this diagnosis, there's a question, and I have a 10-year-old son. Should he be tested for MS for early intervention? Comment?
Yeah, I would just comment that there's no, at the present time, there's not enough evidence that would suggest that spending money, for example, to do an MRI scan of the brain and spine would be worthwhile to do in every single person who has a first-degree relative with MS. The purpose of our study, the RISE-MS study, is try to define if there are other simpler, cheaper approaches that perhaps in conjunction with MRI scans in a targeted population would be appropriate to use as screens. So for example, if we believe that really cognitive impairment may even start before a first clinical attack, if a child who's otherwise trying well in school and is not having behavioral problems is suddenly having a change in their school function and doing less well, perhaps that is someone, and the purpose of our study is to try to define, is that a person that perhaps should be screened? And so the hope with our study is that we'll be able to identify individuals who would deserve specific screening, either a blood test, an MRI scan, or some combination of things. Our study is set up to be, right now, only with ages 18 to 30. The purpose of that is to try to get people before they've actually developed MS, so before the median age of onset, which is 30. But in addition, not so young that we'll have a very small number of individuals who actually end up having the lesions that you can see on an MRI scan that we would call so-called dissemination in space. So we deliberately did not include 10-year-olds only because we thought that the likelihood that if we included a large number of really young kids, the likelihood we actually see abnormalities would be quite low. So,
so the next question is just have one of us respond to this because it's about MRI, and they have to do with what's the difference between T1 and T2 lesions. Do lesions go away? What about use of contrast? Is it necessary to do that? And can you have significant loss of brain volume without having new lesions?
You want that one?
Yeah. So start with T1, T2. When we do an MRI, there's lots of different sequences that are done, and they just allow us to look at the brain through basically different filters. And on one image called FLAIR or T2, MS spots look white. We call them T2 lesions. There's another sequence that's called T1 where spinal fluid disappears and the images in the brain disappear or change in such a way that when there's damage, what you see is a dark hole, a black hole. Those are called T1 black holes. They're the same lesions, just different ways of looking at them. They do help us understand the severity of the disease and aggressiveness. In terms of, do lesions go away? Yes, on highly effective therapies and studies that have looked in the brain, about 20 to 30% of lesions seem to resolve, and we think that's remyelination and repair. Should brain volume be measured on an individual basis? We do that here using fully automated software, but the reality is that it helps us sort of see where people are at now. It's probably not sensitive enough for us to follow on an individual basis. How things are changing over a year or so might be more effective, maybe 2 years or longer. But it does help us sort of see where things are at, and also helps us from a research standpoint because it gives us a very large data set that we can look at to try to answer questions. In terms of the contrast solution, no, people that are on highly effective therapies, the chance of seeing on a random MRI, seeing a contrast-enhanced lesion is quite small. So we don't routinely do contrast-enhanced scans given the IV dye if it's a routine surveillance, unless there's some suggestion there's a symptom or some other problem going on. So we would use the contrast in special situations, but not as routine follow-up. Okay, so switch here to a little bit more about aging and disease therapy. So this question about what if you're over 7 years old, and what's the best DMT for people over the age of 40 related to brain volume? And so why don't you start with those?
Okay, I'll start with that. So the purpose of our DiscOMS trial is to try to determine, is it safe to discontinue a disease-modifying therapy as people age, given that the vast majority of relapses will have already occurred in individuals. The significant number of people will never have relapses after age 55. But the reality is that everybody is unique. And in just the last couple of years, I've personally diagnosed 2 people in their 70s with run-of-the-mill routine relapsing MS, just look like a 30-year-old. So there's no one-size-fits-all with regard to age. But on average, the vast majority of people who are 70 plus who were diagnosed in their 30s, which is the most common, would probably benefit very little, and that's the purpose of our study. Our study will be the largest study ever in people who are relatively older with MS. Even the natural history studies typically don't have 300 people being followed who are 55 and older. They might have 100 or so, but we're actually going to have a significant sort of natural history study that's going on in people who are 55 plus. So if you ask me in my heart what I think that the vast majority of 70-year-olds really derive very little, if any, benefit from these medications that are presently available. However, certain individuals absolutely should be treated in their 70s, and I certainly have people treated who are in their 70s. And I have people who have gone off medications who have had some recurrence of disease activity. Typically, that's very modest, and the vast majority of people do not in the context of being inactive for prolonged periods of time as they age. But everybody is unique, and so picking out one particular medication is going to be difficult. And specifically with regard to brain volume, the brain volume data that Dr. Vollmer showed was across ages, but there's no reason to believe that the data would be particularly different as people age, other than we have not looked at an older age population to see if the benefits on volume persist. And so it would be very important to be able to do that. Our DiscOMS study will not be able to do that because we're not having the MRI scans all done the exact same way on the exact same scanner in all the institutions. So we will not be able to answer the question about brain volume in the aging patient.
Okay. These questions are for Dr. Alvarez, and these are all about ocrelizumab and Tysabri, and they relate to a comparison between the two in efficacy and their mechanism of actions or their implications from that. And then also in use of Tysabri, has there been studies done on balance? Yeah, so it's just understanding the comparisons to drugs.
There's not a ton of data comparing the two medications. There's not a lot of centers that have been using rituximab to kind of be able to get long-term experience besides maybe us and maybe the country of Sweden. And so it kind of limits what kind of data we might be able to collect. We've started to do some comparative evaluation, and for AEN, we'll hopefully present some of this data. The difference appears to be on the order of fairly small between Tysabri and ocrelizumab, with maybe favoring rituximab to be a little bit better than Tysabri. As we get more experience with ocrelizumab, we'll include that into the real-world studies. Because the differences are so small between these drugs, trying to do this as a big sort of clinical trial will probably be very unlikely to occur, just because you would need a huge study to try and show that one drug is better than the other. So that's on the effectiveness side. I think then there's practical differences between the two drugs. There's the issues of whether or not the infusion of once a month, that's a short infusion, and how that fits into your schedule compared to an infusion every 6 months that's a little bit longer, plays a role. What kind of monitoring and things like that you're going to be looking at. I think there's still an effect that we sometimes see with Tisabri that I have absolutely no clue how to explain it. We call it sometimes the feel-good effect that can happen with Tisabri that we can see sometimes with Tisabri and not with the anti-CD20 medications, rituximab or ocrelizumab, that we don't see in everybody on Tisabri. But it's a little bit more than I would kind of expect for just kind of a placebo effect. And so not everybody gets it, but it's something that we're trying to kind of explore a little bit as well to try and understand.
Okay. Just answer a couple of questions along the same line. One is when you use rituximab or ocrelizumab, how long does it stay in your system? Roughly about 3 months. And the question is if you do a massage that moves lymph fluid around in the body, would that increase the effectiveness of these therapies? Would it kill more B cells? And we don't actually want to kill more B cells. These drugs only kill a small percentage of B cells that are in circulation. We leave all the B cells and spleen and lymph node and all the other tissues relatively normal, and that minimizes the risk of infection and other problems. So the people on these drugs at the doses we use, their immune system is pretty much intact. There's not much evidence of immune suppression. And then the difference between killing versus blocking, so Ocrevus versus Tisabri. The reality is, again, that those Tisabri and Ocrevus and rituximab are actually pretty similar in terms of their efficacy and their safety, as long as you're not JC positive. And there was a question: do you use Tisabri when people that are what JC titer would you still use Tisabri? Personally, for me, I don't use Tisabri in JC positive patients because we have so many other options. But you guys want to make a comment?
Yeah, you can go ahead.
Yeah, so sometimes we'll use Tisabri in a couple of special circumstances. So it still remains a little bit easier from a practical perspective to get Tisabri versus some of the anti-CD20s because you have rituximab and ocrelizumab. Insurance companies will prefer one than the other, and it's kind of like trying to have the crystal ball. So for patients who come in and are very aggressive, you do have about a year or two where on Tisabri, your risk of PML is extremely low. And so if you can get it a little bit faster to get somebody started on treatment, I think it's a useful bridge. When they once you get the results back and kind of with time, the risk appears really low if you're under. It's kind of a graded response, but under 0.9, it's a very low risk. We can also sometimes do a strategy of extended dosing where instead of getting it dosed every 4 weeks, we can go out to every 6 or 8 weeks. So the reality is that we do a little bit of that, but I just looked at our numbers last week, and the reality is we have less than 10 patients as a clinic where we're doing the extended dose. I think our number of patients that are JC positive is something like 15 for the clinic. So we're not doing this on for the most part, we're not doing that unless it's special circumstances. And that tends to be patients that have done really well on Tisabri, that just have that feel-good effect on Tisabri, and things like this where we'll leave them on it.
Okay. A couple questions related to stem cell therapeutics, including the lymph cells that are being studied. We want to talk about stem cell therapies in MS?
Stem cells, I think, still hold a huge amount of promise. And so I think it's one of those things that we're going to be seeing this. It's a little bit of a grab bag when we think about it, in the sense that there's a lot of difference in what we mean by what kind of stem cells we're talking about. So you can have hematopoietic stem cells. So these are, true stem cells that can become everything, and you have stem cells that are a little bit more limited, or cells that you can obtain from yourself, for example, that you can get from, you obtain a sample of fat or of muscle or other tissues, sometimes from urine. You take these cells, you make them into some form of stem cell, and then you can make them back into sort of the cells that you need to repair. How you deliver these cells are different. So sometimes whether you put them into spinal fluid and you have to do a spinal tap to put these in, whether you put them in blood. So it's really hard to compare how one center does it compared to somebody else because everybody's doing something different. And so that's limited things a little bit. From a reset perspective, the bone marrow transplants probably are a cure for MS. You're completely wiping out the immune system and replacing it. And so this is kind of the extreme end. The problem with that is you have about a 2% chance of mortality. So MS at this point is not killing anybody, we hope. And so trying to, accept that rate of death, I think, is a little bit too much. And so it's a little bit of I think we need to learn much more about it. The concerns that I have a little bit with stem cells is that there's a lot of centers that are, for the small price of $25,000 to $50,000, are offering to do some form of this and doing it without really presenting any data to kind of show that they're having any effect whatsoever. In the process of doing this, some of the processes give you chemo. So to wipe out part of your immune system, and we know that chemo works really well for MS. We try and avoid chemo for most of our MS patients, and so trying to get longer-term outcomes where the effect of the chemo is worn out to see what the effect of the stem cells is. That we don't have currently, and so I think we need to learn and definitely spend a lot of time on it. My caution is to only do it as part of a study, not be willing to spend a huge amount of money for it, or go to exotic places like Mexico. There's been a lot of reports of, they'll take some stem cells, but these cells were freeze-dried, and then they try to revive them, and unfortunately, they're just injecting dead cells into you. So you're not going to get much of an effect a lot of times in some of these other centers across the world that are doing these treatments. There's been cases of some of these stem cells becoming tumor cells. Again, these cells can become just about anything. And so there's been several case reports of getting tumors being developed from these cells. So just a word of caution about these treatments.
There's a question here that says that it used to be said that the majority of MS patients were not walking 10 years after diagnosis. Not working 10 years after diagnosis. Is there an update on how DMTs are modifying this, and are the studies showing benefit? Recent studies have, in my view, the second generation, more effective therapies have had a dramatic impact on the disease course. Problem is we don't have 10, 20-year data yet, but it looks like it's heading in a very good direction. You guys want to comment?
Yeah, in the beta seron clinically isolated syndrome study, so individuals who were identified after a first attack were treated compared to placebo for 2 years, and then after that, everybody was offered treatment. And then there was an 11-year follow-up of the so-called benefit study. In that study, there were benefits that were seen to those who received the therapy earlier than those who were on placebo earlier. And notably, they did do employment data. And at the end of the 11 years, approximately a third of patients were unemployed due to MS, unemployed and or underemployed due to MS. And that's with a modestly effective therapy. And people were treated relatively quickly. They did not have follow-up on how many of those patients actually continued to use therapy the whole time. Did they change to other therapies or other things of that nature? So I think the point would be that if you had highly effective therapy and were treated from the outset as early as possible, the hope would be that that number would be zero. One of the things we don't measure in a lot of studies is those kinds of things. Patient-reported outcomes. Are you working? Are you working full-time? Are you working to the maximum ability that you want to work? What about your leisure time activities? What about other activities? We can measure relapses and scan changes. That's great. But I think it's much more important to understand the patient's experience as it relates to this. And so one nice thing about this benefit study was that they actually looked at the employment data, and it frankly was a little disappointing because you're talking about the average age of onset was about 30 or 32 in that study. So by the early 40s, a third of those patients were unemployed or underemployed using beta-seron as their primary agent. To me, that represents a failure of beta-seron.
Okay. One quick question is Are antibiotics helpful or useful in MS? The answer is no. There's another question that's actually kind of interesting. So there's a gene editing technique that's been developed now. It's called CRISPR, which stands for Clustered Regular Interspaced Short Palindromic Repeats, and that doesn't mean anything to me. But they're basically viral genes that have been incorporated into bacterial genes, and I don't know exactly how, but the molecular biologists have figured out how to use that to actually go in and edit genes in humans or other animals or plants. So it's a very powerful technology that allows them to sort of redesign the genes in living organisms. And the question is, would that have relevance to MS? I don't know. You have any comment?
So as far as I understand, it's still limited to being able to look at it in the CRISPR mouse, basically, so you need to have sort of the initial setup, but it allows us to at least learn what the effect of the genes is in mice and how those genes will interact with other genes in transgenic mice. And the ability to create a transgenic mouse went from something like almost a year to being able to create a transgenic mouse within like a month or two. So it's allowing us to kind of explore the 200 plus different genes that are associated with MS much better to kind of see what effect that might have in the mouse models of MS. There are some techniques for introducing genes to humans. We've seen recently the approval of some gene therapy techniques for something called leukodystrophy in kids. Some gene therapy studies have been done in patients with Parkinson's disease where they were injecting brain-derived neurotrophic factor, BDNF, and things like this. And so I think these are things that will be within our capability at some point. If we do find that there's differences, that there's a bad gene involved in your immune system and blood cells or something like that, that might be amenable to being able to be edited.
Amanda, you want to talk about Lymtrada positives and negatives?
That may not be on.
Yeah. So this was actually discussed, I believe, Tim, in your PowerPoint, looking at kind of first line, second line medications in the second generation of DMTs. And so Lymtrada is kind of in that category of second line out of the second generation DMTs. And the reason for that is there's a lot of potential dangers with that medication. And so now that we have things like Tysabri, ocrelizumab, rituximab, the side effect profile is just much, much more favorable. One of the biggest side effects really with Lymtrada is the secondary autoimmune disease seen with that. And that is really kind of my focus in terms of clinical and research interests in terms of autoimmune disease. So I get a little nervous sometimes with Lymtrada just because of that risk. And really what we're seeing is the Lymtrada, the effects stay around for about 5 years after the medication. The autoimmune thyroid disease peaks at that 3 years. So there's a lot of monitoring that has to go into place, and it's not a medication that you use and then you're done with. There's a lot of clinical monitoring and things that you have to do with that medication.
Great. Okay. So I'm going to just comment on one. There's a question, it's kind of unique. It's what are the UCH clinical protocols regarding diversity and participant inclusion? Is that specifically provided for? The answer is yes. We try very much to get additional populations in terms of both sex and ethnic backgrounds and racial backgrounds as much as we possibly can. But the reality is this is predominantly a disease of Northern European-derived Caucasians. So if you have any ideas about how we could reach out more to the other populations, the Hispanic, African American, other immigrants from other countries, let us know because we would very much like to include them. And a question about UCH policy regarding patient-centered research on all studies. I'm not sure exactly what that means. I think of all of our research being patient-centered. John, you want to comment?
Yeah, I would comment. Explicitly, the DiscOMS study is funded by the PCORI, Patient-Centered Outcomes Research Institute. But we also have a very large program in place to try to assess patient-reported outcomes as they relate to MS and to the disease-modifying therapies that people are using. As I mentioned previously, while it's important to understand from our perspective, the researchers' perspective, what the outcomes are that are important, it's equally, if not greater, of greater importance to understand the outcomes as they relate to what the patient's perspective is. And so, as an example, in the DiscOMS study, we're including relapses, scan changes, changes in disability, but we also have a very large panel of patient-reported outcomes that if the hypothesis is correct, we actually expect people to potentially feel and function better off of disease-modifying therapies if the hypothesis is correct. So understanding the patient and their perspectives are important. Again, as part of the PCORI program, we have a group of patients and other interested parties who participate in the study from the outset. We also routinely have focus groups and other groups that we actually talk to patients to ask them what their opinions are about what is the nature of research, what are questions that they feel are important. Again, we have a lot of issues potentially with pharmaceutical companies driving the agenda for what kind of research gets done, and I think that it's important to get the medications, but it's important to ask questions that are relevant to patients as well. So we're extremely interested in patient perspective as it relates to outcomes in studies, but also as to what kind of studies to do and the way we think about how they're doing, not just the way we think that they're doing.
Okay. This also is for you, John. It says, how much has UCHMS clinical trial interest in aging and MS been affected by the 2016 Memorial University study that basically concluded that research regarding MS in older patients is being biased towards non-intervention?
Which study? From Memorial. I'm not familiar with Memorial University, so I can't comment on that study. But I would say, since I'm not familiar with the study, it didn't bias me at all when we wrote the grant. I think there's a significant issue in medicine in general, but also in MS in particular, as to what I was just mentioning a moment ago. Who's driving the agenda? Who's coming up with the research questions? Who has the money to do the studies? And I think when we are finished with the DiscOMS study, we will have the largest study ever done in a relatively older age population of individuals with MS. The minimum age is going to be 55. This is unlike essentially every pharmaceutical study with the presently available DMTs. The vast majority have a maximum age of 55 in those studies. Some go up to 65. 65 has been the maximum age. We have no maximum age. If you are breathing, you are a candidate for our study. I don't know if there's an age bias. I think the nature, and I don't mean to say that the pharmaceutical companies are bad human beings or bad organizations. I think they have molecules that are recognized to have a greater impact in those individuals who are younger, and I think that they're trying to determine the utility of these medicines where they're likely to be beneficial. I think the issue for us as researchers, is to not let that define the limits of how we ask questions, and to then say, okay, well, what about people as they age? And you could ask the same question about any of a variety of different parts of medicine. You could ask the question, are there differences in cancer treatments when people age, how you treat diabetes, or a variety of other things. We know there are differences between different racial and ethnic backgrounds with regard to how people respond to different antihypertensive medications. It certainly would be not unlikely that you'd see differences in people as they age as well. At the other end of the spectrum, we've had somewhat of a bias against studying younger patients. What you saw with Dr. Alvarez today was the first ever completed controlled trial in the MS population in people under the age of 18. And had some profound effects. And also, just to be clear, the effects that we're seeing there were compared to an active comparator. So when you think that, for example, Avonex and Copaxone reduced by about 29 or 30% the likelihood of having a relapse compared to placebo, that was an 82% reduction compared to Avonex in those younger patient populations, probably reflecting, as he described, that the disease is much more active. If you looked at the number of new lesions that were seen, even people who were treated with the fingolimod, was actually a very high number. So the patients who are younger have extremely active disease, and yet for many years, without any studies really supporting it, we've simply been saying, well, you know, they're kids, they do well, they remit, you know, they go back to a pretty normal exam, and maybe they don't even need to be treated. And you'll still hear pediatric MS doctors say, geez, you know, I sort of wait and see in how they do. We have a completely different view of the world here based on our experience, and I think that this study will show it. We think that people who need to be treated the most aggressively are the youngest patients. They have shown you at a very young age that they already have active disease. If there's any population of people that needs to be treated at a young age, at a whatever age, it's them. And I think, if anything, there's been a bias against young people as well with regard to treatment. Anyway, so are there biases in how research is done? I'm sure there are. And I think one of our goals is to try to ask the questions that have the broadest implications for as many people as possible. Sometimes you're going to restrict an age population like we do for these two studies I just mentioned. But we are interested in perhaps doing the studies multiple different times in different groups.
Okay, so this is going to be the last one, and I actually pulled this question because I was in a meeting in Phoenix yesterday where we were discussing this, and it's a very interesting question. It says, with the new drugs that are being investigated to help maintain brain volume and prevent progression of disability, will these drugs be available for non-MS patients? In other words, would they be a treatment for aging? And it's a very interesting question because, as we've been talking about, in older patients, which is where progressive disease usually is, the amount of inflammation going on is going down, but the amount of brain volume loss due to normal aging is going up, and so that's contributing to that decline. So it is possible that we could use MS as a model to see whether we could impact aging. And it's possible that if we found a drug that had a substantial impact, really stabilizing or improving function in our older patients in the progressive phase, that might be impacting the aging aspect of the disease. So it's an interesting question, and hopefully we'll find the answer soon. Thank you all very much for participating.
Thank you.
Thank you for all of your great questions, always insightful, and learning a lot today, so appreciate all of your participation. With that, we're going to take a 10-minute break, and then we will reconvene for our healthy lifestyle panel right after that. So please join us after you've had a chance to stretch your legs. Thanks again.
So medical anthropologists make a distinction between treating diseases and treating illnesses. Diseases are what happen to your body. Illnesses are the way they affect your life. So you've just spent a couple of hours listening to our doctors talk about how to treat the disease. And now we're going to have a panel here of experts to talk about how to live with the illness. So when I think about what happens to people's lives when they have MS, I think of your life as kind of a container. And you kind of fill up the container as you grow and age and have relationships and children and jobs and whatever it is that you do. And what happens when people get MS is that you got to put a whole lot of more stuff into the container, and the container gets a little bit stretched. And so part of learning to live with MS is figuring out how to manage what's in your container. Another piece of learning to live with MS is this whole thing that we talk about wellness. And I know that kind of seems like a contradiction when you're talking about living well with an illness. But wellness is about finding some balance in your container for all of the things that are important in your life. So we have exercise and how you eat, and going to the doctor and managing your health and your work and all of that. But other really important parts of wellness are relationships and being engaged in things and your spiritual life and your interests and your hobbies, and all of those things have to fit into your container. And one of the things that happens when people have MS is that a lot of things get thrown out of the container. So our panel today is 3 people who are professionals who work with MS and 2 people who live with MS. And they're going to talk about MS from the outside and MS from the inside. So I think I will just run through really quickly. We have, going from left to right, Michelle King, who's a rec therapist and runs the King Adult Day Enrichment Program. Stephanie Larson, who is a woman who lives with MS and many other things as well. Holly Preen, who's a dietitian in the wellness program that we run and at the university. Linda Makutis, who also lives with MS, and Jeff Hebert, who is a physical therapist and an exercise guru. And he now needs to sit down. Sit, Jeff.
That's
so
pretty hard to do all.
Oh, somebody moving my clock. All right. So I'm going to start with you, Michelle. You are a recreation therapist. What is that? It sounds like a contradiction in terms.
A recreation therapist is someone who uses leisure and recreation hands-on activities to improve someone's overall wellness, well-being.
My grandmother always said that when you got done doing all of your chores, then you could go outside and play. And it sounds like you were saying something different.
Yes. I think you have to build play into everything that you do so that you can enjoy every moment of your life.
Well, so how does this apply to someone with MS? So how do things change when someone has a chronic illness, and what happens to this aspect of wellness, do you think?
I think it's the first thing that we let go. I think that most people with an illness are in crisis mode or survival mode, and so they're thinking about all the have-to-dos, and fun and leisure becomes one of those I should do, not I need to do, and so it gets pushed away, and so you have to find a way to bring it back in.
Do you think, I don't even think it's a should do. I think people think it's a luxury item that has to go.
Frequently, yes, but it really should be I need that in my life.
So I had a conversation with someone the other day about this very topic, and what she said to me was, she said, I have a chronic illness, I have MS, I have children, I have a husband, I have a job, I have about 3 medical appointments a week, I have a physical therapy routine I'm supposed to do, I'm told I need to sit and meditate a half an hour a day to be mindful, and now you're telling me I have to go have fun? Are you crazy? And I have a feeling that there are people in my audience who feel the same way, yes? Yes, all right. So how do you do all of that?
Start small. Start small. No, it's not an immediate, I'm hearing it today, and I'm going to go out, and fun's going to be everything I do. You start today with something small, and you build it up over time. And I mean literally something small. So you have 3 doctor's appointments this week. Do you like to read a book? Take a book with you and read while sitting in the waiting room, which we all know we spend a lot of time sitting in the waiting room. Read it after they've checked you in. You're sitting and waiting for your doctor. If you like to knit or draw, those are all things that you can take into the community, carry with you, and do in small doses so that you can keep doing something that's important and fun for you.
What are some other strategies?
Really thinking about ways you can make changes to how you do it. So if you know you're going to be in the car driving to those doctor's appointments and you like to read, listen to a book on tape. If you are thinking, well, my kids have practice and I have to sit through practice, what can you take with you that you like to do while you're sitting there watching your kids at practice or waiting for them to get out of school or doing all those things that parents do? I myself am equally guilty of it. And I told Pat that I thought about a year ago, oh my gosh, I'm not even doing any leisure for myself. I spend all day talking about leisure and I'm not doing it. And I started setting time aside for me and saying, I'm going to read for half an hour right now. Or I'm going to color a meditative picture, which helps with that well-being and stress. But coloring's enjoyable for adults too. Finding those small things that you can do in small increments that become bigger parts of your life.
So what you're saying is that leisure isn't necessarily a raft trip down the Grand Canyon or a trip to Paris or necessarily going skiing. It's really small things woven into everyday activity.
Yeah, building up to those big things, you know? So if you want to go on a rafting trip and you're like, I just don't have the endurance, or you want to go skiing and you think, I can't do that. What step can you take today to get you to that point in the future by creating those relationships and engaging with where you are today?
And what about adaptations, things that people might check out to enable them to do things that they maybe used to do and that they can't do now, or that are harder?
So knitting, there's a circular loom you can use so you don't have to hold those knitting needles. I personally can't hold the knitting needles. They frustrate me. But there's books on tape. There's books on tape that now do a recap. So when you pause, you can select a recap, tells you what the plot was. There's journals that you can write what you're reading or hearing so that you can remember those things. There's millions of ways that you can do it. You can join an online book club where other people might be also struggling with the concept so that they can refresh your memory too. Obviously, I like reading. There's games groups. There's all kinds of things that you can join to get that support back in.
And what about physical activity? What about things like skiing or bicycling?
Bicycling. There are lots of organizations that actually promote accessible skiing or bike riding. Breckenridge Outdoor Education Center, NSCD, which is National Sports Center for the Disabled, Denver Parks and Rec. All of those programs have adapted recreation, and you can schedule to go and do something adapted with them. They were mentioned in my accessibility webinar, which is on the MS website.
Thank you. So if you want more information about that, please check that out on our mscenter.org website. So our next contestant is Stephanie Larson. Stephanie, let's see. Stephanie is a mother of 3. She runs her own business. She is married. She was diagnosed with MS about 3 years ago, and she was diagnosed with relapsing remitting MS, but unfortunately, she got the relapse and she didn't exactly get the remission because you have spinal cord lesions. So it has impaired your ability to get around. And my experience when people are newly diagnosed is that it takes quite a while for people to get their hands around the disease. And so one of the nice things about a remission of symptoms is that it gives you a little bit of quiet time so you can quietly deal with your MS and your 43 doctor's appointments and all the things that you have to do without having to deal with everybody else in the world about your MS. And when you don't get that, it can be kind of challenging, and you didn't get that. No. So what you told us when we were talking about this was you said that you kind of were struggling and things weren't getting better, and you were having trouble getting around, and life was getting overwhelming, and you withdrew from the world and turned into a roly-poly bug and didn't want to deal with anything. But you didn't stay there, because you're here today. So what happened to turn that around for you? How did you get out of there and back on track?
Well, I guess first of all, I should say I don't know that I'm completely out of there.
Well, I realized,
but I'm trying. You know, obviously, it hit so fast, and I was shocked and grieving, and felt like I was losing ability physically every day, and I was scared, and I was embarrassed, and I'd go out in public, and I'd get questions that I didn't know how to answer. And then I'd fall apart emotionally. Then I'd be more embarrassed because in addition to struggling to walk, I couldn't, there I am sobbing. That makes a bigger scene. So anyway, I withdrew. And so what happened, it didn't happen all at once. But I had a talk with a girlfriend one day whose mom was diagnosed with MS when she was a child, and when my girlfriend was a child. And one day we had a conversation, and she said, Stephanie, when my mom was diagnosed, she went to bed, and I was raised by my sister, and which I don't fault her mother because I went to bed too. But what my girlfriend said is, she said, I really just wanted my mom to be there. She said, parent-teacher conference, everybody else had a mom there. And I just wanted my mom there, even though she said my mom wouldn't come because she was embarrassed about her mobility. She didn't want to use a chair or a scooter. So she wasn't there, but my friend said, I just wanted someone there. And so I started thinking about that and thinking about the 3 kids I have and the fact that they just, you said I wasn't going to cry.
Well, I said it was okay if you cried. I didn't say you weren't going to cry.
I misunderstood that.
Yes.
I just decided that for these 3 kids that I have, that I needed to show up or try to, if I could, physically sometimes just if the fatigue or if I just have one of those beautiful infusions that they talked about that wipe out your cells, then I'd have to stay in bed. But when I could, I decided my kids deserve a mom who can show up or at least try to.
So what kind of strategies? Can you tell us a couple of strategies, 2 or 3 strategies that you used that helped you show up?
The first thing I would say is that we learned as a family, my husband and my kids, we all learned to plan ahead. There's nothing that we do that we just do. Like, we can't really be spontaneous much anymore. For example, I think of my daughter decided to start running cross country, which I smile and support, but in my head I'm thinking, how in the world am I going to get to a cross-country meet? I can't walk on uneven surfaces, dirt and grass, and I'm panicking. But I smile and I say, sure, doll, let's sign up. And then she made it to district, her first season. That's my bragging part of momhood there. And so you can't really have her go to district her first year and not be there. So when she let us know she went to district, was going to district, we smiled and went down to the course where the race would be, and we found one parking place that was close to the one sidewalk that was close to the running trail, which is all on dirt and grass. And so we planned it out where I would park, where I would walk, where my husband would put the seat, where they would run right past and I would wave to her and I would be there. And so that was a good chance to plan ahead. Another thing that I had to do was to adjust to the mobility devices. Like you said, it came so suddenly, and people were shocked because I was normal, like running circles around life, volunteering, running my business, serving in my church, everything, and all of a sudden I wasn't doing that, and I couldn't walk very well, really suddenly. So one day I realized I really needed help walking if I was going to live my life. So I decided that if I was going to use a cane at age 39, that they should be cute and match my outfits and have flowers. And this decision was made at about 2 in the morning when I couldn't sleep because of my myoclonic seizure or jerks because of my MS. So 2 in the morning, I ordered every cute crutch you can find on Amazon. And then I used those for a couple of weeks, but then I started getting questions or comments from people that were like, you're not old enough to use a cane. You don't seem like, you don't have any gray hair. You shouldn't be using that. And then it would send me into this emotional tailspin. And I thought, I was so proud of myself for using this thing. And then I get that, and it went back to the emotional frailty. So one day I somehow, again, laying awake at night, decided that my medical crutch, where is it? It's on the other side. Would you show that for them? It's beautiful. It's so pretty. So then I decided that my medical crutch, this, to me, instead of saying elderly, to me it said medical problem. And it was going to eliminate some of those questions that I didn't know how to answer. The questions like, why can't you run marathons? My cousin's neighbor has MS and she runs marathons. So that has helped. I think another thing that I've learned to do to adjust is to, when I need to show up, like buy my kids some school clothes, and I have to use my wheelchair for that because it's a distance and the standing, and I'm supposed to end on success because my physical therapist says. So I use my wheelchair, but I go to the Kohl's that's in the next town and get in my chair, and I face a whole lot more problems with that. Not that I mind questions, it's just that emotionally sometimes I don't want to answer them. I just want to be a mom. My daughter just needs some new pants for school. So that's been something that's been really important to me, to be able to show up.
So, just for everybody's entertainment, would you share a few of the comments that people have said to you about your MS? Because everybody in this room has had them.
I'm actually going to write a book. Just kidding. But, you know, there have been all sorts. And I hope none of these people are watching on the webcast who've said these things. But I've gotten, how long do they give you to live? That was within the first year of diagnosis. That was, well, it's probably because you're not eating right. Or maybe if you follow this diet in this book I got you, you would be better. And why haven't you tried bee sting therapy? And again, like I said, why can't you run marathons like my cousin's neighbor can, and all sorts of things.
So the strategies that you talked about planning ahead and your crutch and figuring out where to park are all good sort of concrete strategies. But what about managing emotionally? You said that sometimes, that it's a struggle emotionally, and that sometimes you cry, to just be really blunt about it.
Yeah, you know, crying is just not a big deal. I used to think it was really embarrassing. It's just really not. So I do that. And I decided, not on purpose, but over time I realized that I had what was subconsciously being developed as my safe circle. And that was, to define that, I don't even know exactly how, but it's people. I can be with people. I could be with certain people. I can be with people at this early stage of diagnosis, 3 years in, that understand my disease, or who will at least try, or who will at the very least not shame me for not drinking bone broth for every meal. And so...
a kindred spirit, I think.
Because I already feel like, what did I do? What did I do wrong? You know me. What did I do wrong? So when I hear those things, I think, oh, I did it wrong. I should have been eating bone broth my whole life. So my safe circle is people that I don't have to explain everything to. People that, mostly I guess it's people who are okay with the fact that my left leg's not okay. And that sometimes I forget. My girlfriend who's here yesterday driving, we'd gone shopping last night. I forgot which way to turn to go home. I could totally drive, but I didn't know how to get out of the parking lot. And my sweet girlfriend just says, we're just going to go right up here, remember? And I did, she doesn't make me feel stupid. So I just need to be with people who can look at me in the eye when I'm in my wheelchair. I've found that for some people, they are not okay with my chair. Like, you know, everyone's nodding, right? They get all weird. And my kids love Harry Potter, and they call my wheelchair the invisibility cloak. Like, you just get in the chair, Mom, and nobody will see you. Or some people see you and they stare, which is okay too, I guess, but my 13-year-old has taken to staring back. I have to tell her, don't do that. That's not nice. But, you know, it's people who can be okay. We have some friends. I wanted to go on a little road trip, and driving very far distances is not very good for me, but we decided we'd try. Our girlfriend and I, we had an idea. We need to take our kids somewhere. So I said to her, you know, I'd love to do that, but I'm not sure I can. Your husband and your kids have never seen me in my wheelchair. And she said, oh, well, okay, well, we'll think about it. She went home and told her husband that, and he said, well, my goodness, let's meet her wheelchair and get going. So he met my wheelchair. It's really nice. I mean, it's a red wheelchair. It's kind of cute. And so her family met my wheelchair, and then we threw it in the back of the car, and both of our families went on a wonderful road trip where they were okay if I needed my chair. They were okay if I needed to go back to the hotel room and rest in the middle of the activity. And they were okay. Her teenage son would stop and say, you want to piggyback right up those stairs? And it was okay, and I was okay, and they were okay. And we went, and I was so proud of myself when we got back.
So you said earlier that it's a work in progress. So I take it that you haven't figured all of this out yet? Right. But how is it going? How are you keeping in there and fighting the good fight?
Well, it is a fight every day. I mean, every place I go, everything I choose to do, it's kind of there's this thinking process. My husband says, like, I anticipate and with anxiety for days before. Then after I do it, I feel really proud of myself. For example, one of my daughters had a choir concert. Oh, they have them so frequently, you know? I think I get over one, and then there's another one on the calendar. So I love my daughters, but there's a lot of choir concerts. So I go there. It's a really big place. I'm anxious driving there. How am I going to walk in? How many people am I going to see? Am I going to get the bee sting question? Or like, oh my word, what's wrong with you? You were fine last time I saw you. Like, which are okay questions, but I'm just not emotionally. I just want to see my daughter sing. So anyway, I went to my daughter's choir concert. It was anxious, stumbled in. My husband helps me, of course, get in, plan ahead, come as early as we can, get one of the very few handicapped parking spots. And then I got in and sat down and felt this like huge rush of like satisfaction. Like, I'm here. These people, they all take it for granted, the fact that they're here. But for me, like, I'm here, you know? And so I listened to the choir concert and I kind of calmed down. But as it starts drawing to an end, my anxiety gets up again. And I think, oh my word, I have to walk out of here. Who am I going to run into? What if I trip? I don't want to embarrass my kids. But anyway, then I get out. I get in my car, and we're headed home. And I think, oh, that feeling again, I did it. I was there. And I saw my daughter, and I hugged her, and we took a picture, and I was there. And I find that the more I do, the more I think, I can do this. And so I have to ask, sometimes I have to say no. But kind of my test is ask myself, am I staying home because I don't feel well, because I'm not sleeping well, or I just got my infusion, or my leg spasms are out of control? Am I staying home for MS reasons, or am I staying home because I'm embarrassed? Because I think I can handle if my kid, like, I don't want to step out of my kids' lives and my husband's life. If I have any control over it, and I think embarrassment, I can work on that. I can hold my head up and think, I didn't do this. I didn't choose it. But I'll be there if I can.
And do your kids care that you show up with your crutch or wheelchair?
You know, they don't. They seem not to. As in fact, in the past 3 years, like, my youngest, he's just 10 years old. He says, "Mom, you're the best ever." And and he didn't used to say that before I was sick. I'm like, "But even my leg doesn't work." He's like, "Mom, legs don't matter. You're the best." And my girls, it's just changed our family. My kids realize it doesn't matter. I complain about how my legs don't work, and they'll say to me, "Mom, but what we notice is you don't quit." When I'm doing those stupid exercises that an unnamed physical therapist gave me, like, they sit by me. They sit by me and they say, "You can do it, don't quit." And so it's a team thing, and they want me there.
Even with a stupid physical therapist?
He's not stupid. Stupid exercises of my... No, I'm sorry. My stupid exercises from my brilliant physical therapist.
Okay, I think we're going to have a food fight here, and I think we should wrap this up. Thank you, Stephanie. That is MS from the inside. And now we have Holly Preen, who is a dietitian and is part of our wellness program. And so here's my question to you. We talk about staying social and staying involved and staying engaged. And one of the ways in, I think, many cultures, and certainly this one, and certainly my family, it's all around food. Okay, so now we're going into the holiday season, and that's all about food too. So what I've always said to people, because this issue about being able to entertain, and people who used to entertain a lot, and then they get MS and they're too tired, or it's too difficult to do the things that they used to do, so what they do is nothing. And so I've always said, Well, you don't have to have a pheasant under glass. You could have pizza under box and still have the get-together and have the fun. But then, in listening to you talk, you have said that that's not a good, healthy choice. So, I'm putting it back on you, Holly. How does someone stay involved, stay engaged, eat and eat healthy and have fun?
Mm-hmm. So definitely kind of overwhelming to think of that. I think to start with, some of the times it's going to be okay to have the pizza in the box, but just try and make it a little bit healthier. So instead of going for your like regular pepperoni, sausage, everything like that, like I think there's cheese crust stuffings things now. So instead of doing those, getting thin crust pizza, putting veggies on top, putting a salad on the side that's a bagged salad that you can just throw together as a way to kind of modify that. I think you can still do a lot as far as kind of depending, because there's different, if you're going to an occasion and you're bringing something, I think there's some easy ways to bring some healthy foods, which can be, even if nobody else eats them, you've at least got an option for you. So you can do shrimp trays where you buy them when they're on sale in the frozen section and then just put them on a tray to take with you. You get your seafood serving in. You can do veggie trays where you go to the store and just buy the veggie tray and it's already prepared for you. Or you can throw together one with baby carrots and snap peas and stuff that you don't have to cut up and spend a whole lot of time preparing. I think you can also, if you're the one that's hosting, kind of come up with ways that make it easier for you. So if you're hosting a get-together, one of my first thoughts is try and make it around something that doesn't have to be just we get together and we eat. I know one of the things that I did with some friends recently is we got together and did a clothing exchange party. So we all went through our closets, took out the stuff that we don't really wear anymore, threw it all in a pile, and then went through that. So it's not just we sit down, we eat, and then we leave. So I think having something similar to that, I've heard of people having like Pinterest parties where they get together and they do a craft or things like that. So thinking outside of we only get together when we're going to go out to dinner or to have people over for dinner can be good. I think if you're hosting and it's food party, one of the biggest things you can do is ask for some help. So you can either do like a grocery store delivery option so that takes something off of your plate. You could also just ask one of your guests to come a little bit early to help you out with the food prep. In particular, if you've got one of your guests that's a little bit like nervous, more introverted, that might be a great way to get them, hey, like get them comfortable before the party starts, things like that. Yeah.
Okay. Thank you.
Yeah.
So what about holiday baking and all of those kinds of things? Do you have, because that's a big part of a lot of people's Christmas cookies. Mm-hmm. How do you do that?
So my thought for those is one of the things that I've heard of is like the Christmas party where everybody brings the cookie exchange party. So everybody brings their different types of cookies. My thought is if you're hosting, you could do a different kind of, instead of cookie exchange, do like everybody comes, makes a soup, do a recipe exchange, something like that. I think if it's something where you're supposed to go to somebody else's and do that, you could do, there's some really cool stuff online. I just did like an almond flour thing, and it's not a cookie. It uses like 2 tablespoons of maple syrup, but it tastes awesome. So trying to just look for some healthier options when you are doing some of those kind of exchanges and try not to take home a lot, or see what you can do to kind of minimize so you're not taking home 20 other people's cookies.
So thank you. Holly was I think you were the inspiration for the vegetable flavored water that we have. All right.
I love those.
I was initially skeptical about that, but those are actually pretty good. And if you didn't have any cucumber water, you ought to try it. It's pretty tasty.
Yeah, you can do fruit flavored water. I like this one. I think had mint, so you can do some of those where it's just the water infusion. So it's for everybody that hates the flavor of regular water. It still adds some flavor, but it's not loaded with sugar.
Thank you.
Thank you.
All right. So our next panelist, our next contestant is Linda Makutis. Linda is kind of the opposite of Stephanie. She's had MS for 20 years or thereabouts. And for the first 15 years or so, your MS was pretty invisible. So you were, by someone else's definition, a high-powered executive who raised a couple kids, was really busy, and you were able to kind of ignore your MS symptoms for a long time. I think you said that you figured out that maybe numbness and fatigue were just a consequence of having children. I don't know about the numbness part, but maybe up here numbness. Anyway, so you were managing things slowly over time with your MS. And I think I think being diagnosed the way Stephanie was, where you get hit hard and you don't get a reprieve, is really difficult. But I think it's also really difficult when people, I don't think there's an easy way to have MS, oh, by the way. But when people are diagnosed and then the disease kind of simmers down and you're able to cope pretty successfully and keep it kind of undercover and make small modifications over time, you can get lulled into thinking that MS isn't really a problem. And so that's what you did. And I think you said that towards the end, you were traveling 4 days a week and coming home and sleeping 3 so that you could get up and travel 4 more days a week.
Right.
Right. And that you had made some little modifications to be able to manage that, like taking cars to the airport and different ways to kind of manage, but that also masked the problems that you were having.
Absolutely.
Yeah.
And
then the bottom fell out.
Yeah, there was no problem. You know, I could take a car to the airport. I would come home and I would nap for 48 hours, and then get up and do it again.
And what happened?
It's okay.
You still cry after 20 years.
I already cried.
So I worked for a bank. I was a loan officer. On a Friday afternoon, I had a meeting, and I approved a $50 million loan, high-powered by other people's definitions, not mine. On Monday morning, it was sitting on my desk, and I went ballistic on one of my direct reports that this loan was approved, and I had no idea it had been approved. And then I saw that I had approved it, and I had no idea.
So, then what happened?
That was the last day I worked.
Okay.
So go ahead.
So you then had to kind of confront some of the stuff about your MS and develop some strategies to manage both cognitive stuff and fatigue. And those are both pretty invisible symptoms. And everybody in this room who has invisible symptoms will say, I mean, visible symptoms are pretty maddening, but invisible symptoms are maddening too. MS is pretty maddening. But what kind of strategies? Can you give us an example of 2 or 3 strategies that you've come up with to manage?
Yeah, and you guys are going to love this one. So fatigue, gets worse during the day. Taking a nap may or may not help. My husband leaves for work at 5:45 a.m. We get up at 4 so that I can have good conversations. So that's when we talk about things that matter, when I can actually participate in that conversation. I take notes. My house looks like, sticky note heaven. They're everywhere. It's wherever I go, whatever I do, I write stuff down. I forget everything. And here, what was the other side of that question?
We need one more strategy. What's one more strategy?
I get distracted easily. I set the timer on my phone. So, for example, I sit down at the computer to pay bills online. I set my phone for 15 minutes. When the 15-minute buzzer goes off, I'm not paying bills. I'm on Amazon looking at the latest, greatest Christmas gift for my granddaughter, and then the timer goes off, and I'm like, I wasn't supposed to be doing this. So that's another strategy. When I get ready, anything, I live by timers. I live by this routine that I need to stay in, or I lose it. And it's the only way I function. I'm late for everything because I forget I'm supposed to be going somewhere, or I get distracted. And I see a lot of nodding heads. The timer on the phone, the notes, I couldn't function without them.
So you've had MS for a long time, and you've been out about your MS. People know that you have it.
Now.
They didn't know before?
No.
Because I think, but some people did know. And you told us a story about a friend who knew that when you were talking about showing up and showing up on time, and you told us a story about when we were talking about managing other people's expectations, about a friend who knew you had MS.
Right.
And she'd known about it for a long time. You'd been working and doing all that. And you were supposed to meet her somewhere, and you...
Didn't show up.
And that
I forgot.
Yeah. So what you then went on to describe to us is how you've learned how to manage other people's expectations. So how have you done that?
Like, first, so for 15 years, as Pat alluded to, I took the ignored and it will go away stance with my MS. I worked, and very few people knew. Towards the end, I had people that worked for me or with me who were covering for me as they took on more and more of my responsibilities. And I said, it was two-pronged. I was cultivating them to someday take over my job, and they were starting to do my job because I couldn't anymore. But now I'm very forthright with people and tell them I have MS. And if some people whatever. Some people ask, and I try to use that as an education opportunity. That Info MS, Pat had written one, Now You See It, Now You Don't. I probably handed out 100 of those articles to people. And I try to explain, I want to be there. And I give a tentative yes. I don't know the number of things I've missed. But, for example, a bunch of my friends were going to a jazz show, and I had a ticket. And we were Ubering there because you're at a jazz show, you might have a cocktail or two. I was Ubering there because I don't drive after 2 o'clock in the afternoon because I fall asleep behind the wheel or I forget where I'm going. And I sat down, and I never went to the concert because I fell asleep. But these friends sent me a text, are you okay? They sent me pictures of the concert. They taped some of it. And we went over all that the next day. Look, it was awesome. We wish you were here, but this is, not that I missed it, but they understood. And there was no anger and there was no anything. It's just teaching other people that nobody knows what MS is, or very few people, and you're embarrassed. Oh, I have MS. Well, yeah, so-and-so's brother had MS, and he climbed Mount Everest. What's wrong with you?
So you've talked about changing other people's expectations. What about your expectations of yourself and managing your expectations of yourself? Because I think that's a real big challenge that most people face.
I still have high expectations of myself. I get mad at myself. I get mad at MS. But I'm not going to let it win.
So, okay. So I'm going to be the human Kleenex here. Yes. So you were talking about making choices and sometimes changing what you think your life ought to look like in order to make room for MS.
Pat gets me back on track. I tend to wander. So back to the leisure thing. You have choices in your lives. I have a sink of dirty dishes for days because I choose to go outside and go for a walk or sit on my balcony or do something to be part of life and not be stuck in the house, that the housework's going to keep. My grandmother, I swear, is rolling over in her grave if she would look in my house. But I haven't killed anybody yet. And I used to eat dirt as a kid. We all did. You know, it's not a bad thing. But that's the, I make.
And I think it's on
choice.
Holly's diet too. Do you get to eat dirt?
Yeah, it's all natural.
Organic.
Organic, yeah. So,
Yeah. Okay.
but it's choices.
So changing your expectations of how your house has to look or how you have to do things has been
Right.
critical too.
Right.
Okay.
And scheduling. I do things in the morning. I don't do things in the afternoon. I make sure I write everything down. I set alarms. If I have an appointment at noon, I set an alarm for 11 o'clock with a reminder of what I'm doing.
And so when you screw it up, you're kind to yourself.
I am working on that.
Thank you.
But we work on a lot of things. And having it for this long, and now that I'm more out about it, and I am on full disability, people look at me, and a lot of them, I see in their face that I'm scamming the system, or how can you be on disability? You know, and there's the one we all get. You look so good. How can you be sick? And don't we all want to say back, you look so good. How can you be so stupid?
And on that note, I think that's a great. Did you ever really say that? I want to say that.
I am someday. Someday it's going to come out. I'll say it and let you know how.
Okay. So, Jeff, we saved the best for last.
Oh, thank you.
So, Jeff is a physical therapist, and he helps people figure out exercise. And we were talking about exercise because exercise is important for all of us. Is there anybody on planet Earth who doesn't know that now?
No.
No.
And I mean, you said it. I basically coach people, and I want for today. I'm not going to sit down while I talk to the entire crowd because I want to see everybody here. Is that I want you to have some take-home messages and actually some tangible things to go home today with. And one is that I treat all my patients as athletes, and I also treat all my patients as people. And it just so happens that you may have MS. So is it any different for people on this planet that they should be more physically active? Absolutely not. So all the guidelines that we have is that we are thinking about people on this planet.
Okay, so we were talking about the question of exercise in the office, and we were talking about the reasons that we don't. So, and we all know we need to exercise, but a lot of times it doesn't happen. And so what I would like to hear from you are 5 common reasons why people don't exercise and what could be done about it. One of the ones that we came up with at the office, this is one that gets me every time, is that I'm planning to go work out and I have this time set aside and then something scoots in on this end and then I get hung up in traffic and then I only have 35 minutes and then I think, oh, well, there's no point in, and then I can't find my socks. So then there's just no point in doing it, so I'll catch up tomorrow, except that I don't. So what would you do about that?
Yeah, so number one is that as human beings, in our genes, we are sedentary beings. We have always been, and you think, well, no, what about the hunting and gathering? You know, we were very active during that time. Well, we only hunted and gathered when we needed to. And other than that, we were very sedentary as a human race. And we don't have that built-in motivation that says we should be moving around because that's just not built in us. Number one, it's just not in our gene pool. As far as MS, that's why you should come and see specialists in MS in rehab to figure out what the exact barriers to engage in more physical activity is for you. Every patient that comes to me is my N of 1 investigation during that 1 hour. Could be 2 hours if you're from out of town. And we have to figure out which ones those are. However, after 20 years of experience working specifically with people with MS in research as well as clinically, obviously we've got fatigue. Number one is fatigue, and that's a global concern. That's a barrier. Number two, again, first of all, was the just being human. That's a barrier to engage in more physical activity. Number two is fatigue. Number three is limited mobility. And we think that physical activity has to be that we are running, that we're riding the bike for 2 hours, that we are climbing Mount Everest, that's got to be the standard. And we'll get to that pretty soon. But mobility, limited mobility is a barrier for that. Other aspects that's brought to the table with people with MS, as you probably know, maybe spasms or spasticity. That limits also mobility and being able to move limbs freely in space. So with that being said, that's only 4. I know I'm going to get there. So what I'm going to do today is we're going to do a little exercise for the next 30 seconds, and literally exercise. So if you are able to stand up at this given point, please go ahead and stand up. And everybody in the room, I'm not talking just the people with MS. And if you are unable to stand during 30 seconds, I want you to keep sitting. What I want everybody in the room to do right now is for the next 30 seconds is to move your arms as quickly as possible, like you're jogging. Go ahead, keep going, keep going, keep going, move it, as fast as you can, as fast as you can. If you are able, in sitting and or standing, I want you at the same time just kind of march in place. Move those arms, just march, not jog in place, just move. Just move, keep moving, keep moving, keep moving, keep moving, keep moving, keep moving. That's it. Maybe turn your head to the side. Back and forth, yep. 5 more seconds, keep it going. I can see a gentleman over here not moving. You can move those arms, move them, move them. Okay, good, go ahead and have a seat. Is there one person in this room that felt that their heart rate did not increase during that time? No arms came up. So during 30 seconds, you increased your heart rate. You know it came up. You got a little bit, maybe even short of breath. Do you feel like you got a little more energy right now? Did that kind of wake you up maybe? Maybe a little bit. It doesn't happen all the time. So then here's your prescription exercise, is that for 30 seconds, every half an hour, let's say 15 hours of waking day, because you might be sleeping 9 hours. Let's take 9 hours out of that. 15 hours, every half an hour, get up and do that for 30 seconds. Now do the math. If you do that 15 hours, every half an hour, you stand up for 30 seconds and do that, how many accumulative minutes of that activity do you have in a day? 15. Higher math skills. So sorry, pop quiz. You have 15 minutes of accumulative physical activity that is at a moderate level. That's a moderate level. So our guidelines as human beings on this planet, we have about 150 minutes is what's suggested by the experts in exercise internationally. 150 minutes per week. Here comes some more math. So if you add that 15 minutes in one day, in 1 week, how many minutes do you have accumulatively? In minutes. 105. So the recommendations is 150 per week. And what you did, if you do that every 30 minutes, you are tickling that recommendation that we think, oh my God, how am I going to do 150 minutes of moderate exercise every week? You know, I don't have time to do it. I lost my socks. What do I do? But if you just do this, because we have exercise prescriptions, we have tons of them, and I can go on for days about that. However, what you need to consider is more of the guidelines of sitting. Sedentary activity, we now have guidelines, a very strong guideline that just came out this year, that we as human beings should not sit more than 30 minutes in a static position. So if you can think throughout the day whether you can get up and move or not, is that you move a body part. Physical activity is that you're moving a body part. Do that every 30 minutes, you are just about ready to be meeting that guideline.
So I think what you're saying is that this notion of an exercise regimen we make a lot more overwhelming than it needs to be, and that if you break it down, just like everybody else has said about little changes, little strategies, that you actually can knock it without even knowing that you did.
Absolutely. And if you spend some time with me in the clinic, everybody knows that has worked with me, that's what I say, is that purpose your purpose your daily activities. It could be doing the laundry, cleaning the house, doing yard work, going to work. But then at work, if you are at a station that you're sedentary, you got to get up and move every 30 minutes. Just move a bit, 30 seconds to a minute. And now these barriers, there could be limited mobility, but maybe we could, in a rehab aspect, think about how can we prescribe an exercise program to try to get you stronger in your left leg, or work on your balance to eliminate that limitation, that barrier. So there are things that we can then inject that will be more specific to your needs. However, it does not have to be that you have to meet the standard of a prescribed exercise program. Now, the benefit of being on a aerobic or cardiovascular exercise program that's 30 minutes or 45 minutes or something like that at one point, it's still beneficial, but it does not have to be your standard. Don't put that carrot out there. You don't have to put it way out there. You work with what you have right now and what you could do. You don't need, what you just did, you didn't need one stitch of equipment. And if you could not find the time in that to get up, I think you all found the time to get up and do that. So those limitations should not be there, should not be barriers.
So you're saying that my excuse was totally flimsy.
You got it.
It will not work.
You got it.
Oh, no. So one last question for you. People who live in the area can come and see you, but what about people who don't? What's your recommendation for people getting some guidance if they don't have the option to work with an expert such as yourself?
Yeah, I mean, I have been trying to do this nationally to try to change the paradigm of MS rehab to be less reactive but be more proactive, to be more of a coach. As I said, all my patients I treat as athletes because I want you to be ready for your game. Your game is every time you wake up in the morning. And then you go to bed, the next game is there. If you're not prepared for that game, you're not prepared. And thus, we need to be more proactive. I don't have a great answer for that. I've been asked that for years. I do really recommend that you search out a therapist, a physical therapist that has had experience and as much experience as possible working specifically with people with MS. Because my foundation comes off of my knowledge of the pathophysiology of MS so that I can gear it towards you, but then also knowing that you are human and what you need as a human being as well. And that's not easily done. And so searching out, whether through the Rocky Mountain MS Center or the National MS Society, the list of those that are known providers of rehab in MS. But I will tell you, even those, my colleagues, and I'm sorry, but we're not all created equal even then. So it is unfortunately a bit of a hit or miss.
But failing that, people can still get up and exercise vigorously for 30 seconds, twice an hour.
Yes.
Okay.
Because a healthier heart, a healthier brain, we want a bigger brain as long as we can.
Thank you, Jeff.
Yes.
And thank you to my panel. And I think now I'm going to turn it back over to Carrie Chahovic.
Excellent, wonderful panel. Thank you so much, Pat, for moderating, and thank you so much to Michelle, Stephanie, Holly, Linda, and Jeff. That was really great. And thank you all again. Like we said at the beginning, this event is powerful because of each and every one of you and your participation here today. So we hope you had a chance to meet one another, have some great conversations, and thank you for spending just a little bit extra time with us today. I know we're at 12:30, so want to be respectful of your time and wish you a wonderful weekend. It looks like it's going to be a beautiful one. Please go to mscenter.org for all of our education events that are upcoming, including a Conversations on MS event on December 11th with Dr. Vollmer. All of our webinars are archived as well, and we will also be sending out a full video version of the entire Education Summit, including the PowerPoint slides, to all of you and to everyone who registered for the live stream today. So thank you again. Oh yes, and one more reminder about evaluations. As I said at the beginning, we really pore over those evaluations and analyze them and really take so much stock in what you are telling us about what you liked and maybe what you didn't like so much about our summits. So please take the time to fill those out, and our Education Task Force will sift through those, and it will help shape our next Education Summit programming. I also want to draw your attention to, at our information table in the back, we have our latest issue of Informs Magazine. In that, you will find more information about how to develop your own personalized individual strategies for living well with MS. And someone who is here today with us, Nancy Boyd, wrote a fantastic article detailing her own personal strategies. So I'd encourage you to take a look at that as well. Thank you again for being here. Have a wonderful weekend.